We have a lot of decisions to make, and I hope that we can reach consensus on a lot of those today. And I definitely encourage you to ask questions and make comments throughout this meeting, because this is one of the more important ones of the year. Okay. Enough of my soapbox, so let's go ahead and I'll entertain motions on approving the minutes whenever y'all want.
Is JJ so moved?
Okay. Moved by JJ.
Second.
Bonnie is second. All those in favor of approving the minutes as written for February 7th, say aye.
Aye.
Any nays? Okay, well, the minutes from February are passed, and we are going to go straight to the first piece because we have a lot to get through. Kirsten, I think you're going to at least start us with the renewal responses and how do we get to 3.4%?
Thanks so much, Robert. Hi, everyone. It's great to see you today. I just wanted to start the meeting by expressing our gratitude. We feel very lucky to be here today talking to you about things that we are passionate about, to an audience that we are also passionate about. It's maybe a tough deck from the perspective of it's time to dig into some of the more complex aspects of the renewal. We'll have more financials than we've had previously, and maybe we'll talk about some ideas that are a little bit more complex as well. But by the end of it, I think we'll have a great plan going into April, and I'm feeling really optimistic and positive about all of the opportunities that OEBB has in front of it for the next renewal. So with that, let's get started. Our overall agenda, we're going to review goals twice, actually. We're going to review goals and important deadlines once at the beginning, and then just because they are so important, we'll review them again at the end. We're going to spend just a little bit of time level setting on some important historical aspects to OEBB's renewal that will really set us up for the conversation around, hey, what's going on today and what do we want to do for 10/1/23? All right, Maggie, great. Okay, so some goals for today. Here's one big first goal, is for the board to have an understanding of where are we today and why, and what are the major levers at play, and what's likely to transpire over the next month going into April. We need to, if at all possible, reach a consensus on the balance between benefit changes and RSR in our overall balanced approach to reaching a 3.4% renewal increase. And then within that, if the board does decide to approve some level of benefit change, we need to get some more direction and board consensus on what benefit changes we're interested in pursuing. All of that is happening in this board meeting in preparation for April. So coming back to the April 4th board meeting, we will have renewal responses from round 3, which is going to get issued this Friday, and we'll get back from the carriers towards the end of March. That will let us update all of our scenarios around RSR and benefits with the latest financial position. We'll be voting on 3 things in April, and on April 4th specifically. Clinical initiatives. So the carriers brought forth a suite of initiatives. Kaiser had a lot of initiatives focused around treatment efficiency, expanding access to care, providing care for members in more convenient locations such as the home. Those have been through CIAO now and will come again to the board April 4th with CIAO's official recommendation. We'll also have benefit changes and RSR spending levels, again, to whatever level is applicable that the board gives guidance on today. We'll have those scenarios available for a vote. And then the premium rates with the final increase also for approval. That meeting is on April 4th. We do need to get everything approved in April in advance of the May meeting. If for whatever reason we don't make all of our decisions on April 4th, we would then schedule a second board meeting in April to finish all of our decision making. All right, next slide. All right, some historical context. We wanted to show this slide for a few reasons. We know that this renewal, initially when we talked about it last month, we saw that the initial round 1 renewal positions were over 3.4%, depending on what line of coverage we were looking at. They did come down a little bit as part of the round 2 renewal response. And I did want to walk through those with you. And then we'll also put that renewal in context with where we've been historically. So in that middle column over to the right, proposed 2023-24 round 2 renewals. MODA is currently at 4.23%. Kaiser Medical is down to 8.82%. And then the rest of the increases for Delta Dental, Kaiser Dental, Willamette Dental, MODA Vision, Kaiser Vision, and VSP Vision, those are all less than 3%. Some of them are a decrease. When we look at all of the benefit changes in total, the current package at this point is 4.59%. We wanted to put that in perspective. It's a little bit higher than we've had historically, especially since the passage of Senate Bill 1067, which capped the cost increase at 3.4%. That went into effect at the 10/1/2019 plan year. You can look and see on this table, actually, the renewal increase for that year was 4.3%. That's because some taxes and fees increased that year. Without the taxes and fees, the renewal increase was less than 3.4%. And every year since then, the overall cumulative renewal increase, 1.6% for 2020-2021, 1.4% for 2021-2022, 3.3% for the 2022-23 plan year. And when we look at a cumulative basis from 2017-18 all the way through to 2022-23, the cumulative increase is 3.1%. If we add in round 2 renewals, which are not the final renewal position, we still have one more month of partnership with the carriers. Even if we add in the round 2 renewal responses, though, as they are, our cumulative increase is still less than 3.4%. As we're going to see throughout the next hour, there are some complex factors. I know many of you are living those today. There are some complex factors leading to a higher than typical renewal this year. And we, through the board's planning, we have some levers in place to help address that. But in historical context, we can see very clearly that this year is an anomaly compared to the history of OEB, and we're doing a great job managing costs. You, the OEB board, are doing a great job. On the next slide, we wanted to show the same information, but in dollars. Bill's question. So Bill, thank you for clarifying. In terms of, so Bill Grob asked a question about cumulative increases in the 3.4%. So I just want to clarify that the test for whether or not OEB and PEB meet 3.4% is just a 1-year look back. The calculation currently does not permit a multiple year cumulative look back. That's just a metric that we look at because we know in reality, claims costs they normally fluctuate from year to year. You can have positive experience one year, a little bit less favorable the next year, and that can be completely normal. So from our perspective, we get to capture and smooth out that volatility by looking at a cumulative increase, but the test is on a 1-year look back, which is why we're still considering benefit changes in RSR throughout the day. Did that answer your question, Bill? I'll take that as a yes. Yes, thanks, Bill. Great, so this slide just makes the previous slide a little bit more concrete by showing dollars. These are dollars and millions. So it's the same increase and the same trends as before. Now just showing the actual spend on the plan for medical, vision, and dental all together, all carriers by year. As it stands right now for the 2023-2024 plan year, OEB is set to reach $1 billion in spend. All right, next slide, Maggie. We wanted to highlight that the board's accomplishment in achieving a 3.4% maximum cost increase per year has not come at the expense of the OEB members. In other words, we have not been making a string of benefit changes every year to achieve 3.4%. In fact, Kaiser has never made benefits leaner. They've only ever expanded benefits. And MODA hasn't had any plan design changes since the 10/1/2019 plan year, when they introduced CCM 2.0 and rearranged some of their plans. What we're illustrating in this slide, and Kaiser is in pink and MODA is in purple, and it actually goes from oldest on the bottom to most recent on the top. What we're illustrating is that cost share, so of medical spend, cost share refers to the proportion of medical spend that the employee pays. The rest of it is paid by the plan. So this is the employee's portion of cost share, has either decreased or been relatively flat. The reason why cost share decreases over time, even when we don't make any benefit changes, is it has to do with the copay feature of a benefit design plan. So if you can picture maybe don't try to picture your benefit summary, but within a benefit summary, we have some major benefit levers. We have deductible, out-of-pocket maximum, copay, and coinsurance. And coinsurance naturally passes medical cost increases onto employees because the cost share is just a percentage of the bill. So when the bill goes up, the cost share goes up a little bit year over year. But with a copay, actually, that member's portion of the cost share is staying fixed over time. Even though the plan's expenses are growing, the employee's portion is just staying the same. So the benefits wind up getting a little bit richer over time, just naturally when you have copays involved. And we do have a lot of copays involved, both for Kaiser and Moda. Maggie, next slide. This is a really important slide, and we're going to talk about, Bob has a question. Sorry, Bob, your question disappeared. Let me open the chat back up so I can see it here. Does cost share include the deductible paid by employees? Yes. So when we think of cost share, we think of the deductible, the copay, and the coinsurance, all of those out-of-pocket costs that a member is bearing. Yep. Yep, thank you. All right, we're going to talk about RSR, the Risk Stabilization Reserve, many different points throughout the day. So we're going to just set some history here. The reserve fund, we'll call it the Risk Stabilization Reserve, the Reserve Fund, RSR, we mean the same thing. It was established in 2019-20 plan year with the surplus Senate Bill 1067 savings. So just a brief refresher, Senate Bill 1067 did many things. One of the things that it did was anchor hospital payments for certain hospitals subject to the bill. Many hospitals were exempt from the bill if they were rural or critical access hospitals. But for hospitals that were subject to Senate Bill 1067, hospital payments were capped at 200% of Medicare, which was a significant reduction from the level that they were at previously. And the premiums in effect at that time reflected the higher reimbursement levels. And so when Senate Bill 1067 went into effect and decreased the hospital reimbursement, the premium decreased as well. And the board recognized, let's take advantage of this opportunity, not spend all of this savings in 1 year. Let's fund a rainy day fund for future years when we might need access to this money. And that happened, you'll see, in the 2019-20 plan year. The initial seed was $34.9 million. And then there have been some adds and subtracts from the fund over time. We just wanted to highlight those. This was really good history for me to go through as well. In the 2021 plan year, the board made a strategic decision with the Kaiser renewal that added another $5 million to the Risk Stabilization Fund. It took your balance up to about $40 million. The next plan year, the board voted to make some investments. We invested in wellness-based grants, on-site flu clinics, and OMADA, which is Kaiser's pre-diabetes treatment solution. And $2.9 million was spent to buy down the Moda renewal. In 2022-23, no RSR was spent, and the balance was $35.9 million. And that's where it is today. You'll actually see a different number in some of the financial slides. You'll see $34.4 million, and here's why. As part of our round 2 renewal request, we asked the carriers to remove Weight Watchers from within the renewal calc and put it on the side. And under the understanding that we would pay for an additional 1-year extension with reserve funds. That does not mean a decision was made to do anything with Weight Watchers other than fold it into a larger metabolic treatment disorder strategy. And there's a lot of work with CL. So this is just a mechanism to take Weight Watchers out of the renewal calculation itself, pay for 1 year with RSR. And then we also have spent again, just for illustrative purposes only, we've allocated about $100,000 to pay for Virta, which is MODA's proposed type 2 diabetes solution. The CIAO committee voted this morning to recommend to the board that the board adopt Virta. That will come before you for formal vote in April. Just for illustrative purposes, we've assumed that the board would vote to put Virta in place, and that's about $100,000. So in this illustration, the RSR balance is currently $34.4 million. And I'll just pause and see if there are any questions about this. This will become more critical as we go through the presentation and start talking about different ways to spend RSR and how do we maximize the value of our dollar. Depending on how we spend RSR, we get different results. So let's just make sure we're all starting from a good solid page. Michelle, question.
Yeah, I have a question about the reserve fund and just like what are the guiding principles behind deciding when you would spend money in a reserve fund? Because it seems to me that a global pandemic would be a good time to spend down that money, and it seems like we didn't.
Well, I guess I'm not sure. Let me just say a couple thoughts, and then I would like to ask Ali to chime in as well. I think what we're going to talk about today are two different approaches for spending down RSR, or just spending RSR in general. One approach to spending RSR would be, hey, we have a requirement to have our cost increases come in at less than 3.4%. And that's a legislative requirement, and it's really important for our constituents and for ourselves that we meet 3.4%. So in a tough year, and the renewal increases, we haven't come to this slide yet, but the renewal increases are coming in higher this year, in part because of the pandemic. So in a way, the conversation today about spending RSR is a conversation about spending RSR on the pandemic. It's just taken a few years for the impact of that to hit OEB. We'll also see today that there are other ways to spend RSR, more of an investment style approach to spending RSR. So for example, if the board were to decide, hey, let's prioritize certain chronic conditions within OEB or certain initiatives or goals within OEB that might have an upfront investment involved, then the board might decide to spend the RSR on those initiatives. So I would like Robert Young or Ali has anything to add.
Well, yeah, go ahead, Robert.
Well, sure. So most of us on the board are very aware of K-12 budgets. And when a K-12 budget has an ending fund balance, the balance, once it's drawn down, it doesn't recharge. And so when you're trying to deal with an ongoing cost, like let's say COLA in K-12 land, that's an ongoing cost. And so using the ending fund balance to pay for that, the ending fund balance may be able to pay for that year one, maybe year two. But after that, you have to come up with the money to pay for that ongoing cost in perpetuity. And it's very similar to what situation we have. So, in OEA, we talk about the ending fund balance being spent since it's a one-time fund for one-time purposes. So to me, it's very similar.
Yeah, Kirsten and Robert are both correct, and I can speak a little bit to this statutory authority as far as what OEB can expend funds on, and that's limited in some respects, although in statute it specifically states that OEB has the ability to pay down or stabilize premiums, meaning buy down in a risk reserve situation to stabilize rates. I mean, that's really the purpose behind the statutory reserve account. And it does say for other purposes as well. So the board does have the ability to purchase wellness products or services, those kinds of programs as well. So I'd say the real purpose behind the statute is to stabilize premiums, but with that other language around other purposes, the board has looked at funding other programs as well.
JJ, I see your hand up as well.
Yeah, I also just wanted to point out, if we, buy down rates basically using the reserve fund, that will be beneficial for 1 year, but I'll just take some arbitrary numbers. If we buy down the rates 5% this year, and then there's a 5% increase next year, it's actually going to be a 10% increase. So it'll help a little bit, but you're kind of kicking the can to the next year, and you're making the next year extra hard. So using reserve specifically to buy down rates, it would need to be very strategic and minimalistic in that, because ultimately you may be doing more harm long term, even though you're trying to help us short term.
Thanks, JJ. We have some slides that illustrate that idea that you're talking about the effectively you're spending twice as much because of the payback. Jeff, I saw your hand as well.
Yeah, I just want to add to what JJ said, is that if we had a 10% rate increase, we'd be forced to look at options to reduce the benefit levels, which we've tried very hard to avoid, to get back to 3.4%. So that's all.
All really good questions. Maggie, next slide, please. All right, so here's, again, more of a level setting slide going into discussions. We have a couple level setting, more educational slides, just as a refresher for everybody's memory around how plans are rated. And we'll walk through a slide together about what it means when we spend RSR on buy down versus investing. This slide just illustrates at a high level how your carriers came to calculate the renewal increase for 2023-2024. So both Kaiser and Moda have a lot of similarities. There's some differences, which I'll highlight a little bit, but mostly the methodology is the same. So both carriers are looking at a recent historical 12-month period of OEB actual claims, and making a couple adjustments. Maybe there were changes in benefits during that time period, some one-off large claims that we wouldn't expect to happen again, some change in demographics. So that might be a change in OEB's overall average age or gender makeup. And then we're adding an amount for trend as well, saying if I'm looking at a recent 12-month period of claims, let's say calendar year 2022 to make it easy, and I'm trying to project claims for the 2023-2024 plan year, I need to account for the fact that medical costs are increasing during that time period. So I'll add an amount for trend and those other adjustments. That's that yellow bar on top of the blue bar. So the blue bar was that 12-month period of claims. The yellow bar will be some claims trend and some adjustments. They don't always add to the plan. Sometimes the adjustments would decrease cost to the plan. And then we need to add on an amount to cover the operational expenses of administering the plan. Also, changes in taxes and fees. There were none this year. State benefit mandates. And when we add the trended adjusted claims together with the expenses, then we can calculate the required total future premium rate. That's the big purple bar, the dark purple bar. We compare that to the in-force premium level. That's the current level of premium that OEB members are paying, and that will tell us what our rate increase is. This slide was put together just looking at the medical premium too, by the way. When we use RSR to buy down the premium rate, what we are doing is decreasing the height of the purple bar without decreasing the height of the blue, yellow, or green bars, which still accumulate. And it's why next year we have to pay it back. Robert?
Yes, thanks, Kirsten. I just want a clarification on the green box, the taxes.
Yes.
That represents additional taxes and not just taxes on top of the premium. Is that right? Or is it the other way?
So this would be things like PCORI, or when we had the ACA fee, These are pass-through taxes and fees that the insurance carriers would be required to pay on behalf of OEB. State premium tax would be in that bucket as well. So
Okay, so
regulatory
let me try
taxes and fees.
Let me try it a different way. So the in-force premium, does it already include the taxes as well?
Exactly, yes. In-force premium is
Okay.
everything all together. It's the current blue bucket and the yellow and the green all together.
Thanks.
Yeah. Any other questions? Okay, let's go forward a slide. Great. So let's talk about where things currently stand. And the economy is complex right now. I know that you guys are living that as well, just in your day-to-day lives and managing your family budget, noticing that there's been some inflation. Also, we're hearing about it in the news. In fact, there's testimony on the Hill this morning about the Federal Reserve and its plan to mitigate inflation, because the updated inflation data as of February showed that inflation had not cooled off as much as people thought it had as of January. And the economy, as measured by the employment rate, is still really hot. And the Federal Reserve has plans to both increase the interest rate higher than initially thought and also faster. So there's some question about the economy that way. We're definitely seeing higher inflation in the broader economy. That will flow through to the health plans, impacting the cost to hire staff, overhead, to run facilities. All of those pieces are impacted by general inflation. OEB, let's see, I want to talk about OEB specifically, but let's get through the rest of these. We also have a tough labor market, high levels of vacancy and worker shortages, especially in the medical provider community. There was a lot of burnout and early retirement. People transitioned to part-time during COVID. Those vacancies have been hard to fill. They've also been expensive to fill because the job market has been so hot. Utilization is maybe higher than expected. Again, this would be COVID related for a few reasons. During COVID, of course, it was harder to get access to care. Not only were facilities shut down, but for so long, and then it was hard to get back in, but we also had fewer providers actually open and providing care. That delayed preventive care, maybe worsened some conditions that would have been caught earlier. And then we also have worsening health acuity. So that just means how severe conditions are, and morbidity, which refers to how many conditions your population has. Both of those got worse throughout the pandemic. You guys might have read in the news too, especially around mental health and substance use disorder. There was an increase of depression and anxiety in the population as well. So we have all of these complex factors. And then when we think about which ones impact OEB and special provisions that OEB has in place, Senate Bill 1067 does offer some protection in that the proportion of OEB's expenses, and we estimate about a quarter. So the proportion of OEB's expenses that are tied to, that are subject to Senate Bill 1067 are tied to Medicare payment rates. And Medicare payment rates historically have lower rates of inflation and medical cost than in commercial rates. I did want to point out that for 2023, Medicare rates went up a little bit higher than normal to reflect the tougher conditions that providers are facing today. So the point of this slide is not to paint a dire picture. It's just to highlight that there are real reasons why the renewal increases are higher this year. I mentioned medical costs fluctuate from year to year, and that part is normal. Of course, what's not normal is a global pandemic, and we are still feeling the impact of that. And it will take some time to run through the economy and for inflation to smooth out, for provider offices to get fully staffed, for care to get caught back up again as well. All right, next slide. Okay, so with that said, let's take a deep dive into where the renewal rates are currently sitting, and let's talk about some concrete strategies for achieving 3.4%. Let's focus in today's presentation on the medical renewals. So in round one, the MODA medical renewal was 5.5%. As of round two, it is 4.23%. Part of that was a revised trend assumption. MODA got more refined on an assumption around regulatory impact that we'd worked with them on. And then also Weight Watchers was removed from the renewal calculation and put on the side. We will be going back to the carriers in March, as I mentioned, with a round three renewal request as well. That puts MODA's current increase at 4.23%, which means MODA has about a $5.4 million difference to make up to get down to the 3.4% increase cap. And then if we look at Kaiser Medical, Kaiser initially came in at 8.91%. Kaiser's system is a little bit unique from MODA in that Kaiser feels immediately the impact of provider vacancies and having to fill those vacancies with potentially higher cost workers in the short term because their contracts are all on a 1-year annual basis. Whereas with MODA, their providers will have multi-year contracts that have been and will be rolling in over time. So there's a little bit of a timing difference contributing to this as well. Kaiser's initial renewal was 8.91% on the medical with an additional month of experience. That was better than what their trend had assumed. The renewal is down to 7.82%. Notably, where Kaiser did make the most movement in round two was on the dental. That's the next line below. In round one, they were proposing a 0% renewal increase. On the surface, that seems great, but OEBB was actually calculating that it required a -7% decrease. So as part of their round two renewal request, they were asked to reconsider that and proposed a -3% decrease as part of their round two response. I've highlighted a couple things in orange and some things in green. So the two orange items, that's MODA Medical and Kaiser Medical. Together, the two medical carriers would be 15.0 million above the 3.4% cap. It's about, and then the dental and vision carriers collectively are coming in 3.9% under. One decision the board would have would be to immediately decide to subsidize the medical overage with that dental and just look at achieving an $11.1 million gap. And that's 1.15 percentage points away from 3.4%. So we have some work to do, but it's definitely doable. And we have some good levers to be able to do it. I want to stop there and make sure we have any discussion and answer any questions people have. Jeff.
So Kirsten, does the Mercer team feel that, or judge, maybe a better word, that the renewals on vision and dental are appropriate for the coming year? So they are positioned that we could approve those, or do you think there may be some more to glean from that?
The only question I have outstanding on those coverages, I think we need to look at the Kaiser renewal as a package of medical, dental, and vision, and leave the dental renewal on the table as part of the discussion over the next month. Otherwise, the dental and vision renewals are in a good place.
Okay, thank you.
JJ.
So, JJ, thanks.
I was just gonna say it is the 3.4 mandate is total cost increase. So I think it's appropriate to look at the totality of all of our insurances together to hit that number, not just medical.
Great, thanks, JJ. And for the next couple of slides, once we start looking at scenarios, we do target 11.1 million. So you'll see that number again. All right, Maggie, next slide. Thank you. All right, next one. Okay, so let's talk about some principles that we were thinking about for achieving 3.4%. These aren't necessarily the same principles as spending RSR, But they are a good way to level set the next couple of slides and maybe a framework for how the board might come to consensus on where it's going to land. So we see these as a four-legged stool, or four pillars holding up our 3.4%. So the first one is conduct negotiations, and this really means partnering with the carriers to help lend a critical eye and our expertise and external opinion on the renewal calc and the reasonability of the assumptions, and integrate things that we're seeing and we notice in those conversations. We saw that reflected in some changes between round 1 and round 2, and we'll continue to work with the carriers over the next month as we prepare round 3 financials. Also, we have the guiding principle, and this was an OEBB board goal, of improving efficiencies. So where possible, the carriers and Mercer are going to scrutinize available opportunities and data to identify opportunities for increased efficiencies. Kaiser and Moda both came to the table with a portfolio of programs designed to treat your members and increase access. When necessary, we look at making benefit changes, and we see this as a periodic indexing of benefits that align with the board goals. So they have some other value besides just rate buy down, and address changing units in cost, changing unit cost. I'm sorry, I typed risk stabilization reserve. It's actually rate stabilization reserve. Use risk stabilization reserve as a balancing item to mitigate benefit changes. And so we see these 4 things together as working to achieve 3.4%. Next slide, Maggie. Okay, let's dig into this slide. There's a lot of really good stuff here. We'll walk through it together. First, before we even dive into the slide, let's just talk about it at a high level first. And this is the idea that we touched on at the beginning of the presentation with Michelle's question around what are the things that we can do with RSR, and do we get different value from doing different things? So one approach with the rate stabilization reserve is to buy down rates. And because you're not actually addressing the underlying cost of care, it's more like a loan in that situation. So we're borrowing money from a pool of money to artificially decrease premium in 1 year. But then next year, we have to pay the loan back and also still come up with the necessary premium. So RSR, when it's spent to buy down rates, it is an important component of an overall balanced strategy because it does help mitigate the need for other changes, for example, benefit changes. But we just want to highlight that we're effectively getting 50 cents on the dollar when we spend RSR that way. The other way to spend RSR is in seeing RSR as a pool of investment money, and specifically investing in initiatives that would increase the long-term viability of the program, improve member health long-term. For example, VERTA, which is the type 2 diabetes treatment solution Moda's proposing for 10/1/23, stops the progression and then ultimately reverses type 2 diabetes for members. So that's a situation where we would make an upfront investment in the program in exchange for a long-term cumulative payoff. So this table illustrates just an example of what that might look like. And I know it's a little bit complicated, but I wanted to walk us through the power of using RSR as an investment versus as a buy down tool. Our beginning RSR balance we saw earlier on is 35.9. As I mentioned, it's within, the board hasn't voted on this yet, but just for illustrative purposes, we've allocated 1.4 to pay for Weight Watchers, which came out of the renewal calc, and 0.1 in VERTA, which is that line RSR invested in clinical initiatives. In this scenario, for illustrative purposes only, we have used $5.1 million to buy down the renewal increase to reach 3.4%. But you'll see that I've actually subtracted $10.2 million because we would have to spend 5.1 this year and set aside 5.1 to pay it back next year as well. So we've really spent 10.2 million when we do that. If we think about and maybe JJ mentioned this as well, if we think about wanting to maintain a positive balance for the future, maybe for a future year where claims fluctuation is not in our favor, we might set aside a certain amount of money for a rainy day fund. Just for this illustration, we've set 10 million aside in our rainy day fund, and that leaves the RSR balance line of 14.2 million. So this is saying if we spent $10.2 million on buy down, set aside $10 million for future rate stabilization, that would leave 14.2 million to invest in shift left clinical initiatives. If we spent $5 million next year, assuming that we had in place a 2-to-1 ROI requirement, every dollar of RSR invested in clinical programs then would return $2 the following year in long-term return. So we really just want to illustrate there's no value judgment on spending RSR on buy down versus clinical initiatives. They both have value. They do different things. They come with a difference in return on investment. The ROI of spending RSR on buy down is 0.5, and the ROI of spending RSR on shift left clinical initiatives would be 2.0. And we have some slides. We'll get to these more when we talk about specific balancing scenarios, because ultimately it's going to be a board decision. Where do we want to land on the spectrum of, if we have $11.1 million, we could fund all with benefit changes and none with RSR, all with RSR and none with benefit changes. Those are the two extreme ends. Somewhere in there, the board will come to consensus on what is an ideal amount that balances the needs of all of our stakeholders, that balances short-term and long-term. We will see more slides as we go on that show some concrete options for this. The overall goal of this slide, though, is just to illustrate that we have different ways of spending RSR that drive different results. I'll pause there. I know this slide is maybe more complex, so if there are any questions or want to have any discussion, that'd be great. Ali.
Thanks, Kirsten. And I would just add a quick comment that, it's funny because the legislature, gave the board the stabilization fund and the authority to spend to buy down rates, but then they put a 3.4% cap on a few years later that adds a lot of complicating factors. But yeah, I just want to make the comment, that they did give the board the stabilization fund for a specific purpose. So I wouldn't see it as a stigma, just more of a challenge.
Thanks, Ali. Next slide, Maggie. Bill.
I was just wondering if you had a quick comment on what you see in the industry, be it in Oregon or the US, on the next 3 years of healthcare costs.
That question is to me, Bill.
Or whoever. Right.
Whoever would like to join. I'm sure yeah, there are lots of different perspectives about that. Ali, were you going to raise your hand?
You go ahead, Kirsten.
Yeah, I'll speak on behalf of the carriers too, as we've been having lots of conversations with them. Also, just a general understanding of the economy and the time that it takes for recessions to resolve, for inflation to calm down, for things to return to normal, especially given how long they were impacted from COVID. I think we're thinking that a recovery could go into 2024, potentially even 2025. I know that the carriers would echo that as well. Tom?
Yeah, I sit on the value-based purchasing work group, compact group, and for OEBB, and the Oregon Hospital Association has asked to be. They were asked to participate in this, and the chaos that's happening in hospitals and health systems is such that they're asking for a 2 to 4 year kind of grace period before they participate in more complex value-based purchasing, but saying that the environment is going to be pretty dynamic, fluid, difficult, over that period of time. Now, does that mean that we're going to see the 10% or 8% inflationary impact that we had this year? Probably not, but there's disruption. There's disruption in the force, no question, and it's going to be here for, at least from the hospital standpoint, for again, they're saying 2 to 4 years.
JJ?
Yeah, one other thing, you look at market trends, and I will, at least one board member's opinion is I will push very hard when I hear healthcare system saying this is going to be an extended high cost event based upon inflationary patterns, because the reality is from June through December of last year, inflation was 0.3%.
Yeah.
So we'd had 2 years of insanely high inflation, but I'm not willing to listen to the healthcare system saying costs are rising due to inflation.
Yeah, JJ, the issue around inflation is the lack of healthcare workers and the impact on wages, particularly where people have needed to bring in travelers. I'm just reporting what they said, and my hope is that you're correct.
Well, and my only stance is I think they're liars. I don't believe the systems. I don't believe that some of it's true. Traveling nurses are insanely expensive, but these are the people that their cost increases are double what CPI is for the last decade. So I think Reed is the propagating it. So
I understand what you're saying, and it is a complex. Let's hope it's in. Let's hope you're right. I hope you're right.
Yeah, absolutely. Michelle?
I mean, I guess I would just add that from a member perspective, what folks see is that it's harder and harder to get care because of the shortage of providers, and yet our costs keep going up. It makes absolutely no sense.
Yeah, it certainly is a tough dynamic. I can see that. Somebody else has their hand up. Let's see. Oh, Michelle, did you put your hand up again, or maybe it's from before? Oh, I see it. All right.
Right.
Yeah, perfect. Okay, so this slide just gives a couple concrete visuals for some potential approaches. And again, you know, obviously, just to reiterate, the board can come in anywhere in that spectrum. These are just a couple examples from that spectrum to illustrate what it might look like. So we have scenario 1 off to the left, which looks at making up the entire 11.1% difference with RSR. So we'd be spending $11.1 million on RSR this year, setting aside another $11.1 million to pay it back next year, and that would leave a remaining reserve balance of $12.2 million. And then scenario 2, 3, and 4 look at different balances between benefit changes and RSR. And I do, you know, when we go back and forth between percentages and dollars, you know, it's helpful to look at both. Percentages put things in perspective, but also they're not concrete. When we look at dollars, they're more concrete, but it's hard to get a sense of scale. So we have over on the right just a couple of guiding principles. Spending the rate stabilization reserve involves balancing competing priorities, short-term versus long-term, spend versus invest, protect cost share in the near term versus potentially being able to invest more in health for the long run. These 3 benefit scenarios. So scenario 2 is a $4.0 million total benefit change, Kaiser and MOTA together. Scenario 3 is a $6 million benefit change. Scenario 4 is an $8 million benefit change. Those are roughly 0.46% of premium, 0.7% of premium, and 0.93% of premium. So even scenario 4 is still less than 1% of premium in terms of benefit change. And then the bottom line shows the remaining RSR balance. And every dollar that you shift from using rate stabilization reserve to buy down to benefits really kind of gives you 2 to 1 back in your RSR balance. So in the scenario 2, we'd spend $7.1 million this year, pay it back next year with another 7.1, $4 million on benefit changes, and the reserve balance is 20.2 million. In scenario 3, we would spend 10.2 million in total, 5.1 this year, 5.1 next year to pay it back, and 6 million in benefit changes. Our RSR balance goes up to 24.2 million. And then in scenario 3, we're spending 6.2 million in total from RSR, 3.1 this year, 3.1 next year to pay it back, $8 million in total benefit changes, and our remaining RSR balance would be 28.2. And again, these are illustrative scenarios to give the board, hopefully, we're starting to get a feel now for where in that spectrum is the right balance for you all. And then we'll have some discussion and come to consensus too. Any questions on this slide before we move on? Okay, Maggie, next slide. Some of us are visual, so I put together this slide actually to just help me visualize the different scenarios and thought it might be helpful to share with the broader group as well. Bill, the additional question is if we will need to use RSR next year as well. Yeah, you know what? It's so good. Let me pause on this slide and just answer your question directly, Bill. A couple slides ago, we put a hypothetical example together that showed setting aside RSR for a future rainy day fund. And that is really, we've talked about using rate stabilization reserve to buy down this year's rate. We've talked about rate stabilization reserve as an idea of investing in future rate buy down, but really via investment in clinical initiatives. And then there is this third component though, which is the RSR balance that the board wants to save for a future rainy day fund, especially if we're thinking about, and again, we think differently about this, but maybe there are some perspectives that inflation might take a while to flow through the economy. We hope it doesn't, of course. But thank you for highlighting that. It is definitely a question for the board to ponder as it thinks about how to spend the RSR balance. Is it prudent to leave a positive balance for future years? Yeah, absolutely. So this is just a visual that shows the 4 different benefits and change scenarios, 0, 4, 6, and 8 million, along with the ending reserve balance in that scenario. So we're talking about $0 to $8 million in benefit changes and 12.2 to 28.2 reserve balance. And we get that leveraging again because of that buy down payback phenomenon that happens when we buy down rates. Maggie, next slide. Okay, so we're going to pivot at this point in the presentation and get a little bit more concrete about what might some benefit changes that target these amounts even look like. We wanted to set the stage with some OEB enrollment. I like to see where do OEB's membership fall by plan. For MODA and Kaiser, so we'll highlight both MODA and Kaiser have the most members. These are subscribers. So they have the most subscribers in their richest plans, Plan 1 for MODA Medical and Plan 2 for Kaiser Medical. There was buy up for 10/1/22, which actually means members had an opportunity to move into a richer plan if they chose. Potentially contributions went up or other factors were at play. For MODA, plans 5 and 6 are the next most populated plan, and for Kaiser that would be Plan 2A. And this is just an FYI for you to have in the back of your mind as we go forward and consider some benefit changes. Maggie, next slide. This also is an FAQ slide, but I will highlight a couple things. This is not the comprehensive list of benefits. We specifically called out some benefits for MODA and Kaiser that we might look at changing for the 10-1-22 plan year and highlighted them here. So if we wanted to go back and say, well, how does that benefit look for MODA, or how does that benefit look for Kaiser? We could look at a specific benefit change in the broader context. So we have deductible, in-network deductible for MODA with the new CCM 2.0 plans. They're actually the in-network coordinated care tier deductible, and then a slightly higher non-coordinated care tier deductible. For Kaiser, those range from $400 up to $2,000 for Plan 7. Kaiser plan has 4 plans. They range in deductible from $0 deductible Plan 1 up to $1,600 deductible for the HSA Plan 3. For the inpatient admission, all of the plans are at a coinsurance except for Kaiser's traditional Plan 1. The coinsurance levels are 20 or 25%. Outpatient surgery is also all a coinsurance 20, 25%, except for Kaiser Plan 1, which is currently at a $75 copay. The office visits vary depending on the plan. Typically, they're a copay in the neighborhood of $20 to $30. Specialty copays are typically anchored to the office visit copay, but at a slightly higher amount. The philosophy there is to just get members to think, because the cost of that office visit is higher, we want to make a little bit more financial incentive for members to use care wisely. So the copays would range more in the neighborhood of $30 to $50, $30 to $40 for Kaiser. The HSA plans are at a coinsurance, that's IRS rule. We do want to highlight with advanced imaging, MODA PPO plans put advanced imaging, so that's CT scans, MRI, in the additional cost tier, which has a $100 copay. Currently, the copay for advanced imaging with Kaiser is $20 to $30, other than the HSA plan, so we will see that. Within the ER cost share, we're at a $100 copay for most of the plans, coinsurance at the HSA plan. And then the pharmacy, the benefit is shown as well. We have one scenario around pharmacy benefit changes. So we can use this as a reference if we want to come back to it. Maggie, next slide. But this does play into, as we were thinking about approaching benefit changes, we want to make sure we're doing benefit changes in a thoughtful way that is providing some other value to the plan besides just lowering the premium rate. And so we thought of some principles that we could maybe all center on as we approach what benefit changes we want to make for OEBS members, if any. Our first principle is that benefit changes represent a long-term strategy, not an annual solution. I think that's highlighted in the history of the board's decisions. We've never decreased benefits for Kaiser and haven't for MODA since 10/1/2019. So this is not something that we do every year. It's not part of our routine renewal process. This is really a special lever, that we pull sparingly and with great thought and consideration. Carriers should share benefit changes in proportion to their total premium. Kaiser enrollment accounts for 25% of medical premium, and MODA's about 75 million. So as we look to benefit changes and reaching that $11.1 million target, we were looking at benefit changes for Kaiser and MODA in that ratio. We think it's important to prioritize benefit changes that further the triple aim. So the triple aim is this idea that we can improve access to care, improve the quality of care, and also decrease costs. So within those 3 levers, do we have the opportunity to make benefit decisions that further the triple aim? For example, the reason we have an ER copay, an emergency room copay, that's waived upon admission is because we want to steer members to the urgent care and their primary care provider, but we don't want to make an undue financial burden for someone who is truly having an emergency. So we waive the copay upon admission. So an ER copay is an important lever in steering towards cost-efficient care. That's an example. Another example is increasing the Kaiser specialty scan copay to encourage more thoughtful consumption of care. It also means preserving current cost share levels for preventive care and chronic care management, making sure we're not adding an additional financial barrier for members in that area. Another priority for benefit changes might be to align designs across carriers. So we know we have some geographic differences in what plans are offered to what geographies. So we could look to make common changes for both carriers, such as ER copay increases or out-of-pocket maximum increases. We could also look at one carrier and make a change if it brought it closer in alignment to the other carrier. For example, the specialty scans copay and an increase in the Kaiser Plan 1 out-of-pocket maximum would bring it closer in alignment to Modus Plan 1. We also want to make sure that a package of changes makes holistic sense and not sending a confusing message to the member. Okay, so with that framework in mind and our background on RSR and benefit changes, let's look at a couple scenarios. And I know it's tougher in person to have real-time dialogue, but as we go through these 3 slides and look at different scenarios, ultimately keeping in mind our goal of gaining consensus today around what to look at in more detail and what to refine for Mercer over the next 4 weeks so that we can come back on April 4th, that first time at that first board meeting with a package of a holistic package of reaching 3.4%. That the board is ready to vote on at that point. So as we think about these feedback, please give us feedback as to whether this is an area of benefit change or an amount. How do you guys feel about that and what you want to see? And we'll try to help facilitate a conversation to ultimately come to a consensus by the end of the meeting. So this is scenario 2, which is the 0.46% of premium benefit change scenario. It's a total package worth $4 million. We have some stuff on the right that just visually shows what that would look like, current alongside proposed changes. And then on the left, we describe what the change would be. So for Kaiser, this is looking at that specialty scan copay, which today ranges from $20 to $30 for advanced imaging such as CT scan and MRI, and would increase it to $100 for Plan 1 and $200 for Plan 2A and 2B. The MOTA $3 million package, because again, we want to get to a total $4 million package. We could look at increasing the ER copay from $100 to $150, maintaining that protection for true emergent scenarios by waiving the copay upon admission, and then increasing the out-of-pocket maximums for all plans by $250. So that's what that looks like here. So for Plan 1, the out-of-pocket maximum would be $3,100 up from $2,850. And then for Plan 7, the out-of-pocket maximum would be $6,750 for the coordinated care tier up from $6,500. So $250 increase across the board. This is just one option, and this is the $4 million benefit change scenario. So I'll pause for a minute, and I'm hoping to get a reaction and thoughts from the board if you're willing to share. JJ.
I'm not a big fan of increasing out-of-pocket maximums. We have some of the highest out-of-pocket maximums of any public sector insurance provider. And so there's other levers I'd rather choose. I'm okay with the idea of benefit changes in a tough year like this. I'd be more in favor of like a $5 increase to copays or something like that. I just think our out-of-pocket matches, we have a long-term strategy to try to get those closer to what our other public sector entities look like.
Great, thanks, JJ. And Bill, I saw your comment as well, seconding JJ's input. That's great direction. Thank you. Other comments from the board?
Just to highlight, this is Tom, to highlight what JJ said, what it does, out-of-pocket maximums hit people who are receiving a lot of care. And,
yes.
The hope, the idea of insurance is to spread it around. And from a equity standpoint, I think it's, if one can avoid increasing out-of-pocket maximums in general, if there's other alternatives, it's probably better to go in that direction.
Yeah, thanks, Tom. And Bill added a comment, also keeps our low-income members out of getting healthcare services. Yeah, it's so interesting. Every benefit lever does different things, and it's a trade-off. I mean, really, benefit changes that drive a dollar impact, and if like they impact people, right? If they didn't impact anybody, they wouldn't have a financial impact to the plan. But to your point, Tom, they impact very different groups of people, and it's a trade-off. You know, when we think about out-of-pocket maximum, you're right. The out-of-pocket maximum impacts people who are using care, whereas the deductible impacts everybody and more people. Versus office visit copays might impact everybody, whether they're getting preventive, you know, more of like primary care versus chronic care. Wanted to see a chat comment too. Yeah, Sue appreciates bringing an equity lens to this conversation. Yeah, absolutely. There's the equity lens is an important aspect of this conversation, and recognizing that the benefits are a trade-off between who we're impacting and how many people we're impacting. That's great. I made notes about that out-of-pocket maximum and the copay. Maggie, let's look at the next slide and see some other benefit design scenarios. So for scenario 3, thanks, Michelle, for your thoughts. Also echoing that sentiment about out-of-pocket maximum. So for scenario 3, this is a $6 million benefit package. Here are a couple other options or levers on the table. We could look at increasing deductibles for MOTA for plans 1 through 6. Just thinking that the plan 7 deductible was already fairly high at $2,000. We've talked about the out-of-pocket maximum change already, so that was helpful guidance. So on this slide, let's focus on the deductible change and see what we think about that. Also, in this scenario, we have the Kaiser proposal to increase specialty scans copay and then increase the ER copay. And again, we're going to protect members who are truly having an emergent episode by waiving upon admission. So I'd like to get your guys' thoughts on the deductible and the ER copay as potential benefits to look at.
So Kirsten, I'm not opposed to it in theory, but if we do not have the increase in the out-of-pocket maximums, I don't know how much these would have to go up to compensate, since scenario 3 is built on scenario 2.
Yeah, I have deductibles somewhere in my email. Yeah, I hear you about that. I think probably we would look at the deductible in conjunction with one other change so that it was not a bigger change in the deductible unless the group preferred to keep things simple. We can do several smaller changes. We can do one bigger change if we decide the deductible is the right lever. We can look at what deductible change would be required. We can also say we want to limit our deductible change to $100. What would be another benefit change that we might make? Probably a copay change at that point. So increasing the specialty office visit copay $5 and increasing deductibles $100 for an example.
Tom.
I'm looking at the proposal for the Kaiser Permanente part. The idea of specialty advanced imaging scans being greater than $20 and $25 makes a lot of sense. So I don't know if $100 is the right answer, or $200 or $150. I don't know. ER, everyone, $100 has been the kind of going rate since 2000. So the idea of it increasing some, and again, I don't know if it should be 100 or 100, I mean 150 or 200, but the idea of increasing those is also not out of whack with my experience.
Thanks, Tom. And we'll see on the next slide, MOTA. We also have the impact from MOTA to increase the ER copay. So if we wanted to do that, we could do that and keep it in alignment with both carriers as well. Tom, did you want to have another comment too? Your hand is still raised.
No, but
Okay.
Kirsten, I do. The ER copays being having a way to leverage people to going to more low cost opportunities does make sense, because we're trying to get people to use the best level of care, so that would make a little sense to me.
Great. Thanks, Robert. That's all really great feedback, you guys. That's perfect. Maggie, let's go to the next slide. Okay, so this is illustrative of a 0.93% of premium benefit change, $8.0 million package. We have two different Kaiser options to show. Will give us an ability to talk about a couple other new levers. Let's look at MODA first. We've seen the ER copay already. I know where you guys stand on that one, as well as the out-of-pocket maximums and deductibles. This just simply says we would do all three to reach $6 million. Kaiser, we could get to a $2 million package with Kaiser simply by changing the out-of-pocket maximum on Plan 1. Maggie, do you mind going back to that table of benefits, please, that I included in here as a reference? Thank you. So increasing, so I just wanted to point out right now, the out-of-pocket maximum for Plan 1 on Kaiser is $1,500 compared to Plan 1, $2,850 for MODA. So this proposal to increase the Kaiser out-of-pocket maximum would still keep it richer than MODA. Yeah, thanks, Georgianne. Yes, the specialty scans for PEB is $100 too. I know that we've talked about out-of-pocket maximum already in a global sense, and that who we're impacting when we increase the out-of-pocket maximum. We may have equity concerns with that. I think this is a little bit the same, a little bit different, in that we're not making a global change to out-of-pocket maximums. We're simply maybe indexing one of the richer plans that hasn't had a benefit change ever and is currently at a $1,500 out-of-pocket maximum. Thanks, Maggie. If you want to go back to that scenario 4 slide, that'd be perfect. So I'd ask the board just to comment, does this feel the same to you as increasing out-of-pocket maximum? So we still have an equity concern and would prefer to look at other benefits first, or does this make more sense to you if we're limiting to just Kaiser Plan 1? Maybe not a lot of strong feelings
I
about
feel
that.
less negatively about it just being one than across the board.
Thanks, JJ. All right, let's look at the right side of this slide. I'm just making sure I update everything in my notes correctly. On the right hand of this slide, we're going to take a similar approach to Kaiser and look at a couple smaller incremental changes. Bill's question, what about driving more members into the efficient coordinated plans? Yeah, to think about, let me take that as a takeaway, Bill, and think about the ways to do that would not increase costs. I'll make a note. We'll give this some good thought. So it's a good question. Okay. All right, perfect. Okay, thank you for suggesting that. So in option B, this is MODA's $6 million package. It's the same thing, it's on the left, but now we are using a couple smaller Kaiser changes. So we have that specialty scan copay increase to $100, $200. To Tom's point, those aren't magic numbers. We're just trying to index to something closer to where MODA and also PEB are at. Increase the ER copay, again, indexing there. And then the new benefit change here is increasing the specialty office visit copay just by $5. So taking that from $30, $35, $40 up to $35, $40, $45, which does put it closer in alignment with MODA. The office visit copay for MODA's richest plan is currently $40. So I'd ask the board to comment on maybe two things here. Do we prefer fewer changes that are bigger? Do we prefer more changes, but they are smaller? And then what do we think about the specialty office visit copay change?
JJ.
I appreciate having closer alignment between Kaiser and Moda, so if the changes makes them similar, I'm more in favor of that. Also,
Tom?
I'm all right with a
Oh.
bunch of smaller ones instead of having a substantive change that's one. I know it's a little confusing when there's lots of changes, but when they have a smaller impact, I think that is a better impact on an individual member.
Thanks, JJ. Tom, what's your thought?
Tom?
I agree with what JJ just said, and in particular, I find increasing the specialty office visit by $5 across the board more attractive than out-of-pocket maximum, just as a personal opinion.
Great, thanks, Susan. I
And
see
also
your comment as well.
multiple small changes avoid having one population kind of getting whacked. It spreads it out across the entire membership, which I think is better in general.
Yeah, I love that insight, Tom. It's a great insight. Yeah. Great. And Susan, we saw your comment as well. Smaller changes, smaller impact, alignment with MODA. That's great. Any other comments? Otherwise, what I would like to do, we have a little bit of time left, and what we haven't talked about yet that we really need to before April is hone in on the sweet spot from the board's perspective on the balance between benefit changes and RSR. So we can do that. If you, I wonder, sorry, my son's school is calling me and I feel like it might be an emergency. I wonder if I could just take 1 second and answer the phone and come right back. All right, thank you.
Well, I hope the board chair isn't also required to be the master of ceremonies. So hopefully everybody's okay with the silence.
Could take that break a little bit early, Robert, if you wanted.
Well, let's do
if
that.
she
That
comes
sounds
back.
like a great idea. So I have to go back up to the agenda. We're scheduled for a 10-minute break. How about we do that right now? We'll come back at 2:28.
Great.
All right.
Oh.
We're going to have a 10-minute break, Kirsten.
Break, yeah.
Okay, got you. Thank you for the update.
You good, Kirsten? Everything fine?
Yeah, I have to go pick my son up. He's growing up in the nurse's office. So
Oh, no.
yeah, it's unfortunate.
I know what that feels like. I've been there. I'm not in your son's thing, going to pick up a kid. Right?
Yeah, that's great. I'm going to touch base with my colleague, John Kessler, and have him take the rest of this home. I felt like we got really great direction on what benefit changes to pursue. And now what's left is to just decide how we want to split that $11.1 million out between RSR and benefit changes. And
Yeah,
so
we can
I'll,
cover that,
yeah,
Kirsten.
perfect.
No problem.
All right. Well, thank you so much, you guys. I apologize.
No worries. No
Go
worries.
take
Good
care of the
luck.
kid. That's
Yeah.
All right. I'll see you guys soon.
right.
Take care.
Okay. Bye.
Ali, are you on the interview committee?
Or
OHA director.
no.
I shouldn't ask you this because we're recording. Never drop the question. Right.
I don't think I am anyway. No
Yeah.
worries.
Josh, your window behind you is turning you into a dark shadow. There you go. Now we can see you.
Hi. Am I late to this meeting?
It started at 1.
Yeah, okay.
We're on a break right now.
Oh, gotcha. I'm hoping to potentially ask a question of the OEBB at some point, and I wasn't sure when the appropriate time was for that.
Did you submit a public comment form?
No.
There's a public comment section at the end. We'll have to let Rose know that you're here to make a public comment. Usually you have to submit a thing 24 hours in advance saying you're going to make a public comment, but I think I don't speak for others. I'm a board member, but I don't control the policy of how it goes. If you can put in a text to Rose on the chat box saying you're here to make a public comment, maybe she can respond to you accordingly.
Okay.
Right.
Thank you.
Rose Mann. Oh, go ahead.
Josh, I'm Rose. That's okay. People, you can give a public comment. We'll just let Robert know you're going to do it. You only have 5 minutes.
Okay, great.
Okay.
Thank you.
And if you have something in writing that you can submit to me, that would be great. I mean, your public comment in written form, that would be good too.
Okay, is there an email address to do that?
Yeah, it's on the website, but it's rose.man@DHS OHA. I can't think of it when I'm not at dhsoha.state.or.us.
Where do I find this on the website?
It's on the website.
Yeah, just go to the OEB website.
Hey, Rose, this is Margaret. I will go to the website and pull up the link and then I'll put that in the chat. Just give me a minute.
Okay,
Thank you.
thanks, Margaret. Trying to do 3 things at
I think
once.
Jackie just did. Jackie just put it in the chat.
Great.
Yay, Jackie.
We're all just so excited to have a public comment for a change.
And if you can just be on video off, mute off until the public comment appears. Or you'll get squashed down when we start presenting after the break again. But yeah.
Okay, so break is over. Ali, is Kirsten back?
Actually, this is John. I'll be standing in for Kirsten to finish this out.
Okay.
Yeah. So if everybody's ready, we can get moving. And again, really appreciate the board's understanding that we're both consultants and parents. So very much appreciate that. So let's dive in. So I think before the break, we got very good guidance from the board in terms of, JJ was talking about bringing greater alignment between the benefits of Kaiser and MOTA. And then also, I think there was several people had chimed in about the smaller changes rather than the larger changes, so that they're spread, across the impact is spread across the membership more evenly. So now our goal in kind of rounding this out at this point is really what is the mix of changes that the board might want to look at in terms of the mix of benefit changes and spending a reserve to achieve the 3.4% goal. And again, this is really looking at all those permutations. So as you can see, if you do no buy down, you're going to have to rely solely on benefit changes, and then vice versa. If you're going to do all buy down, you don't have to do any benefit changes. So I think that that's really what this is illustrating, is that those options. And again, I think this is really just to help guide the thinking. And this isn't something that needs to be decided today, but it also helpful in kind of thinking about that balance. And let me just kind of stop there, see if there are any questions, and really looking for the board comment in terms of the mix of benefit changes and buy down that makes sense.
Well, John, I think the chart and the graph are helpful to, guide us for April, for sure.
Yeah. And I think I think it's really just almost philosophical question, almost more in terms of what that mix should be. And it's going to be kind of hard to get an answer until April too, because again, we're, as part of round 3, we're hoping that the rates will come down a little bit too. So they'll, that there won't be as much of a need to lean both on buy downs and benefit changes to achieve that goal. Okay, if there are no questions or comments, we'll go on to the next slide. And this is, again, I think we have some of the guidance that we just talked about, but maybe we can just kind of go through this more systematically. So in terms of out-of-pocket maximums, it was sounding like that was more of a no than a yes. Don't know what the most efficient way to go through this might be. So definitely heard that there was more of a yes on the specialty office visit copay.
I think what would happen is if we rank these like 1 through, I think there's 7, it would out-of-pocket maximums would be 7. There may be a situation where you had to do it, but it would be what I heard was it was at the low end of the at the low end.
Yeah. Well, actually, that's a very good point, Tom. So maybe a good way of going through these and instead of trying to make a ranking or something ordinal, just kind of, interest, high, medium, low, and deductible was any thoughts in terms of deductible, in terms of was that a low?
I was thinking more of a Pareto, like I would put out-of-pocket maximums at a 7 and RX copay at a 6. And I'm working my way up the line here, right? Anyhow, that's how I'm looking at this chart right now.
So Bill's saying RX copay is also low. I think deductible is kind of that low to medium. I think we were the idea of coming up with under the specialty scans, particularly that one was really focused at Kaiser Permanente, was I think high, because there was some interest at trying to get it more in sync with what MODA was
The
offering.
MODA. Yep, exactly. Exactly.
The specialty copay, I think, would be high because it was a relatively small hit, but over a larger period of time. And I would, my personal, and people can change it if they think. I'd put ER copay medium and outpatient surgery copay medium.
I'm also leaning towards ER copay to high, as long as that waiver, if you get admitted, it's waived.
Yeah,
that's fine. I'll go with that.
I think that in some ways, you could also, the outpatient surgery copay could be the same as
Sure.
high, just because it's
Sure,
one of
you
those
can put it
things that's
high.
aligning Kaiser and MODA, right? Because today
Why don't
Kaiser
you put
has.
it high? And why don't you change deductible then to medium, so we at least have one medium? Just for
Wow, this
So
is a. Yep, go ahead.
I was going to say to the board, I'd like to hear more feedback from everybody else if possible. I mean, I know high is relative, right? Nobody wants to make any of these cuts, but it's relative, right? So I'd love to hear feedback from other people on the board, because this is what Mercer's going to take back and retool their package.
Okay, I'll speak up.
Yep.
Jeff.
General statement, I'm in favor of making incremental changes on a fairly regular basis, because not only do they address problems of today, but they have future impact as well. So as we bend the curve, it lessens some of what's going to happen a year from now. The concern that I have about ER copay, and why I wouldn't do that high, is because of some of our more rural regions where they may not have the choice. And so I think we need to be sensitive to that on the coast, the Northeast, and even in the Southeast. So that can be problematic. As far as specialty scans, alignment is good. Specialty office visits, need to go back and look at it. I think I'm all right with high, but maybe medium. RX copays, yeah, we're doing a lot in that area already, but that's fine. Outpatient surgery, they should be aligned. And out-of-pocket maximums, I have heard JJ make that argument, I think 3 years in a row. So I think it's probably time we listen to him on that.
Okay, we're going to go JJ, Michelle, and Sue. So JJ.
I kind of mirror with what Jeff said. The one thing I will say that no one has really said is we're looking at how do we make up an $11 million delta. I don't think it's $11 million. I think that we should plan for less than that. I think there's still a fair amount of movement from the providers. And I think if we send the message that we're willing to increase, our members' costs and RSR to make up the 11, the carriers are less likely to move, and they're happy to take that money. So I don't think we should plan on $11 million. I think that we should plan on a fairly decent amount less than that.
Thanks, JJ. Michelle.
Regarding the ER copays, just thinking it through to like some of the negative effects that could have. People go to the ER like after hours when urgent care is closed, and I mean, I feel like my kids always have to go to the ER on like Sunday night when I normally would have taken them to urgent care, and it's always a hard decision because if it's like appendicitis and we decide not to go until the next morning, that could have really bad consequences. So just, thinking about increasing barriers to that kind of care, I think we want to be really careful and maybe err on the side of not increasing costs.
Great comments. Sue. Okay, no, Sue. Anybody else? All right, John, I think you can continue then.
Yep, no, I think that this is, I think this is helpful feedback. And also definitely take JJ's point to heart in terms of, you know, we're also hoping that we'll see additional movement. So we're not trying to, you know, that it's something smaller than $11.1 million gap that's looking to close here. I think the other thing to think about too is that if you're going to make benefit changes, you know, this goes back to some of the principles we were talking about earlier, that, you know, you want to have a package that makes sense. You want to make sure that it's, you know, achieving some of your other goals, like bringing in greater alignment between the Moda and Kaiser benefits. And then also, you know, recognizing that this is not something that you're going to do annually. I think that's the other thing too, that, you know, so in some sense, you know, you want to make that worth your while as it's really something that you can't do every year. And, you know, it's something that you want to just do incrementally every couple of years. Okay, let's, oh, Ali?
Yeah, thanks. I just wanted to make a quick comment. Next meeting, we'll come back with a little bit more of a full OEB financial picture. The RSR funds are a reserve account derived from savings from the hospital cap a couple of years ago on Senate Bill 1067, but you also have a stabilization sub-fund that's been built over the years on interest earnings, other admin excess that's gone into reserve, and it's a significant amount. So I just want to make sure that, you know, you don't only have that RSR fund, that there is more funds in reserve that OEB has that you can, I guess, make a decision so you're not committing 25%. You actually do have quite a bit more money than that. So we'll bring that back to the board next month so you have a full picture.
Jeff?
Yeah, I think if we go back to when we first established an RSR, it was a bit of a windfall. Yeah. And our intention was not to have an operating RSR ad infinitum. It was to take that and feather it out over time. So, you know, we have the other reserve that Ali just talked about. So I really think it's a great idea that Kirsten brought up about spending some of that RSR on investing in future efficiencies. That just makes a lot of sense, that we take a first-year startup cost, spend it on that, and then engage into the premium when it's starting to be a net savings, if it realizes its potential.
Sue put her question in the chat because she has a sound issue. I only say that because she mentions me.
Yeah, thank you, Bill. I mean, my only other comment is I agree with all of that. And Jeff, I really resonate to your comment relative to the, you know, ER may be it for our rural communities. So the question really is, how can, you know, what capacity do we still have that can move to a more coordinated care where we know that there are potential savings as we're looking at this list and thinking about the impacts relative to that. So that was it, but thanks, Bill.
Tom?
The catch with moving to coordinated savings, I mean, more coordinated care, my guess is that we have, because they're a separate plan, we have lowered their cost to members, and there's not, I'm not sure if there's savings there because we charge lower premiums. That's my concern about that as the saving grace. Don't get me wrong. I think we should always be looking at doing things in organized fashions as much as we can. But it may not be at least the way that we've adjusted the premium, we've shared that quote savings with the people who choose those plans.
Okay, any other comments? Yeah, I mean, I think that's part of the challenge with that is, also the contributions are set by the entities too. So again, what we can do, as Tom pointed out, is impact the premium on the CCM plans. So I think this has really been helpful. So, for us at least, it's given us good guidance moving forward. And I think the other challenge is really just, someone asked early on, what is this going to look like several years down the road? And I think that's the challenge. So you're gonna not want to necessarily spend all of your reserves in 1 year. So I think that's another consideration, as we move through this process, just because we don't know what the future holds. With that, I think we'll move to the next slide. And again, this is really just documenting what we'll be doing over the next couple of weeks. So the thing is that we'll be receiving the next round of renewals, towards the end of March, and we'll be factoring in some of the guidance that you just provided to us now, and also looking at the new rates and mixing those together to come up with some scenarios that get us where we need to go to that 3.4%. And then we're looking to finalize the clinical program recommendations that were initially discussed today, the CIO meeting, and that will be happening, during this month. And then looking forward to April, the next meeting, April 4th, we'll be bringing those clinical initiatives to the board, and then we'll be packaging those combinations of benefit changes and reserve spend, based on where the round 3 rates come out, and then to the extent that we can get everything resolved on April 4, there won't be a need for a second meeting, and if there is a need for a second meeting, there'll be another meeting to make the renewal decisions in April. So that's the road ahead for the next month.
Okay, any final comments or questions on what we're going to be working on in April? Okay. Well, then I think we're ready to move on to it's John and David from the Standard talking about short-term disability and the impact of PFMLI on that.
Yep, is
Great.
David on?
Yes, I am.
Okay, David, I'll just kick us off and then I'll turn it over to you. So
Great, thank you.
Again, so paid leave Oregon. So what we're trying to look to get covered today is a little bit about the history and the background, what it covers, coordination between paid leave and short-term disability, the rate impact of assuming that the short-term disability coverage is maintained, and then we'll kind of close with some proposals to streamline, because this presents rather a unique opportunity to streamline both the STD offerings and the long-term disability offerings. So I think that this is what we're looking to get covered today. And we're partnering up with David and the Standard and we'll the Standard will be covering much of this, and then we'll close with some Mercer reactions to the proposals of the Standard.
Great. Thanks, John. David Scarce with the Standard. I'm a national account consultant. I've been working on OEBB since its inception back in 2008. So I'm going to be talking today, what John said, about paid leave Oregon and how that's going to interact with short-term disability and kind of what we see happening with that plan going forward, and then as well as talking about some potential plan design changes moving into the next plan year. Next slide, please. So I'm assuming that most of you know what paid leave Oregon is. However, I will just give some, a broad overview for those of you that may not be completely clear on it. So paid leave Oregon is a paid family medical leave plan that other states around the country have been implementing. Washington implemented this 3 years ago, for example. New York was the first one back in 2018. What is paid leave Oregon? Paid leave Oregon is a program that's going to ensure individuals and employers and families have have protected leave as well as paid leave for certain situations, and we'll get into what those situations are just a little bit later. This is effective as of September 3rd, 2023. So right now, for the employers that are participating in the state plan, their contributions began as of January 1st of this year. And that contribution is 1% of wages up to $132,900. That contribution is split between employee and employer. The employee is paying 60% of that 1%, and the employer is paying 40% of that 1%. And so I've got an example here. If an employee is making $1,000 in wages, that means the employee is paying $6 and the employer is paying $4. Next slide, please. So paid leave Oregon covers family leave, covers medical leave, and covers safe leave. So unlike family medical leave today, the federal PF, the federal leave program today, this is a paid program. So in the past, if you were to go out with FMLA to take care of a family member, you had to cover that with whatever funds you had available to you. And then additionally, if you went out for your own health condition, that could have been paid or unpaid if you had a disability coverage like short-term disability. So this plan is actually going to pay individuals when they're out for family leave, such as bonding of a new child, to take care of a family member. If you're out for your own health condition, or you can also see, or Oregon has something called safe leave, which has to do with domestic violence, sexual harassment, things like that. Next slide, please. A lot of words on this slide. I'm not going to go through all of it, but this is just really an overview of what the program is. What you need to know is that anybody that earns $1,000 or more in the last 12 months is eligible for this program. So that means it's not just full-time employees, it's part-time employees all the way down to $1,000 a year in earnings. So it's a pretty broad program. I mentioned the contribution of how that works. The waiting period for this program is 0 days. So if I went out one day to take care of a family member, I can actually apply to get paid for that under this program. The maximum benefit period is 12 weeks. There are some additional weeks that could be available to you when we're talking about pregnancy leave under the Oregon Family Leave Act. But in general, the way you look at this program is it's a 0-day benefit waiting period, and you get 12 weeks of benefits every 12 months. So that 12-week period starts when I take my first leave. So it's not that every calendar year I get 12 weeks, I get 12 weeks every 12 months, starting from the first time I used it. Was there a question that popped up there? Okay. And you can see here the qualifying family members, spouse, child, parent-in-law, siblings, grandparents. It covers the gamut. The one thing that also Oregon does that's pretty unique is Oregon has something called affinity. So if you are really close to your next door neighbor and your next door neighbor has a condition and has to stay home and needs to be cared for, you could actually say, I have an affinity for my next door neighbor, fill out a form, and you will get paid to stay home and help that next door neighbor. So again, it's a very broad and generous program. In addition to the qualifying leave piece of it, for family care, like I mentioned, there's also the medical leave. So in today's world, if I am injured, I stepped off a curb and I got hit by a bus, I either have my short-term disability to cover me, my sick leave, what other forms of income I might have available to me. Under the Paid Leave Oregon plan, you will actually be eligible for up to 12 weeks of benefits under this program for your own health condition. And then the last thing I just want to point out is currently the income replacement level is 120% of the state's annual weekly wage. And that right now is $1,469.78 a week. They are going to, they meaning the state, is going to review this every July. So this is what it is as of July 1 of 2022. We fully anticipate this is going to continue to increase. And so when they go and look at this in July 1 of 2023, I would anticipate that this average wage is going to be above $1,500. And I guess one last thing to point out is that this program does provide job protections that, just like FMLA does. This program also provides job protection up to 90 days. Next slide, please. All right, so the big question is, how is this going to interact with your short-term disability plan that currently offered through OEB? As I mentioned, the current maximum benefit for paid leave Oregon is essentially $1,470 a week. The maximum benefit under the short-term disability plans offered by OEB today is $1,500. So if you do the math, that means the most someone's going to end up receiving on their short-term disability plan is $30 because Pay Leave Oregon is going to be considered a primary benefit and considered deductible income under a short-term disability plan. So if you have somebody, an example here, if you have somebody earning $50,000 annually, they're going to receive $879 a week from Paid Leave Oregon, which is a 91% income replacement equivalent, which far exceeds any income replacement that they would receive under short-term disability, which leaves a minimum benefit of $15 that's payable under the short-term disability plan. So you actually have somebody earning $50,000 a year, for example, that's going to get a 93% income replacement when you pair their Paid Leave Oregon and their short-term disability benefits together. The only time that this is not going to be the case is if you have a member that has exhausted their 12 weeks of Paid Leave Oregon and then has another condition that occurs. So if you had an individual that was out on a pregnancy leave and they used up between their, their pregnancy recovery and their bonding leave, they used up all their 12 weeks. And then 4 months down the road, they fell off a ladder and hurt their back. They now have no Paid Leave Oregon to fall back on. So the only thing they have, if they're enrolled, is their short-term disability plan. And in that case, there's no Paid Leave Oregon, so the short-term disability plan will pay out, fully as it normally would. The other case where you might have somebody getting greater than a minimum benefit under the short-term disability plan is if you have somebody who is actually working outside the state of Oregon. So if you have somebody that's working in Washington, you have somebody that's working in California, you have somebody that's working in Idaho, they're not eligible for Paid Leave Oregon, so they would continue to receive benefits under their short-term disability plan just as they do today. Any questions on that? All right, next slide, please.
David, I just want to emphasize this because I think it's an important point as to why it's worth maintaining the short-term disability. I think because I think that's probably a key question that's probably going through people's head is why do we maintain this? And I think part of it is the example that David just went through, which is really you exhaust the medical or you exhaust the family and to make sure that there's still benefits available. And again, there also might be some other benefits that are available through STD that are not available through Paid Leave Oregon. That might be like something like return to work or what have you.
Correct.
So I think that just wanted to make sure that we address that because I'm sure that's a question going through people's mind. Absolutely.
Yeah, I wouldn't recommend removing all the short-term disability plans for the reason John mentioned right there. I mean, this is really going to come down to kind of a personal choice for individuals. If they know they have Paid Leave Oregon, they're already paying for that. Do they also want to pay for short-term disability? Well, their short-term disability premiums are going to be significantly reduced, so it's going to really cost them practically nothing to continue their short-term disability plans. So employees really just have to decide, do I have other forms of income available to me so I don't need to worry about continuing a short-term disability plan, or because the premium is going to be so low on that short-term disability plan, does it make sense for me just to continue having that as a stopgap measure just in case? And so to talk about what we're proposing under the short-term disability plan. So we went back and we looked at all this, and knowing how rich the paid leave Oregon plan is, and you know, what we kind of see from a claim utilization standpoint. Once you get you know, the reduced benefits of the maximum someone's ever going to receive is $30 a week, unless they fall into those other two scenarios I mentioned. We're proposing an 80% reduction in the short-term disability premium. This chart here kind of shows how this falls. So currently the premium under short-term disability, close to $2.2 million, about $1.7 million in claims. And then we have our, you know, expenses to run the business, to pay the claims, the risk charges. So as you can see now, with the 80% reduction, you're now looking at going from 2.1 million and 2.2 million essentially down to 435,000. So we do see significant, you know, reduction in premium, significant reduction in the benefits payable, with the paid leave, you know, with the integration of the paid leave Oregon plan coming in September. Next slide, please. So I'm going to tell you what our proposals are, and I believe John Mercer is going to, you know, kind of piggyback onto this and say what they think you should consider doing as well. So as I mentioned, we're looking at reducing the premium for the short-term disability plans by 80%. I believe it also makes sense at this time. You have 30 short-term disability plans currently, which is pretty good because we started out at 56. So we've got it down to 30. Hey, that's a good milestone right there. With the short-term disability plans, you have maximum benefit periods of 60 days, you have maximum benefit periods of 90 days, and then you have benefit waiting periods of 7 days, 14 days, and 30 days. So that's kind of why we have these plans all over, as well as income replacements of 60%, 66 and 2/3, and 70%. So I think with paid leave Oregon coming in and being a 12-week benefit, it makes sense that we should probably go ahead and eliminate all of the plans that have 60-day maximum benefit periods. That way, whatever's happening with short-term disability is kind of dovetailing with what's going on with the paid leave Oregon plans at that 12 weeks. So we're eliminating those 60-day plans. We're maintaining the 90-day plans. And then additionally, given that paid leave Oregon has a 0-day wait, I would recommend that we eliminate any benefit waiting period on the short-term disability plan that's greater than 7 days. So you have a 7-day wait, you have the 14-day wait, you have the 30-day wait. We would remove the 14-day wait and the 30-day wait. So that would leave you with short-term disability plans with 7-day benefit waiting periods, 90-day maximums, and we would continue to offer that benefit percentage income replacement between 60 and 70%. We actually had eliminated a couple of the plans that I would say we would need to bring back. So that's why I'm saying we're going from 30 plans down to 8, because there were actually a couple of plans that we would need to bring back. I think if you look at what we currently offer and just said get rid of all the 60-day plans and get rid of all of the benefit waiting periods greater than 7, I think that brings us down to 5 plans. But then I was proposing to bring back a couple of plans to make sure that the folks that are enrolled in short-term disability have a corresponding plan today. If they were in a 60-day maximum, that have a corresponding plan in that 90-day maximum. And as you recall, under the short-term disability plans, there's the voluntary plans that the employees pay for, fully voluntary, they pay the premium, the benefit's non-taxable if they receive it. And then there's the mandatory plans, where one plan is mandatory, where the employer pays it and all employees are enrolled. And then there's a mandatory employee paid plan where all employees are enrolled, but the employees are paying the premium. So that's by paring this down to 8 plans, we still kind of cover all of those bases of the voluntary plans and the mandatory plans. And then on top of that, as John mentioned, I think this is a great opportunity to look at the long-term disability as well, because again, we're talking about the integration. So if we're removing these 60-day maximum short-term disability plans, it would make sense to remove the 60-day benefit waiting period plans on long-term disability, so that we're dovetailing only 90-day plans with the paid leave Oregon plan and with the 90-day maximum short-term disability plans. And so by doing that, that's going to eliminate, from 26 plans down to 15 plans. And then on top of that, there were a couple of 180-day plans that we had put out there at one point. There's never been any enrollment in these plans. Those plans were put out there You know, the 180-day benefit waiting period plans were put out there as a inexpensive option if employers wanted to offer this on a voluntary basis to their employees. We never had anybody offer it. We never had anybody enroll in it. So I think it's probably makes sense to eliminate those plans as well. So what I would propose is this reduction from 30 plans down to 8 under the short-term disability plan, and from 26 plans down to 15 under your long-term disability plans.
David, I have a couple of questions.
Yeah, go for it.
Yeah. So my first question involves the 60 to 70% and how it integrates with PFMLI, because as the salaries get closer and closer to say $100,000, the 70% rate that you're mentioning actually drops down to closer to 55%. So would these short-term disability plans actually cover the gap between, let's say, the 55% and whatever the income replacement that you choose?
Today, as the plans are currently structured, they have a $1,500 maximum. And so we weren't proposing making any changes to that unless there was interest in doing that. Because essentially what you're doing is you are creating a plan that's really income protection for higher wage earners more so than the lower wage earners. And those plans tend to get a little bit more expensive. And then you end up getting the lower wage earners supplementing the higher income for income replacement, higher wage earners for income replacement. So as it's currently structured today, and that's the way it's been since 2009 and inception, the short-term disability plans had a maximum of $1,500 a week. So that's the world they've been living in today.
Yeah. So for the for most, let's say for most teachers who are in OEB, then the short-term disability won't provide a supplement at all. It's just it's a plan for if you run out of PFMLI, then it's there. Is that an accurate statement?
More or less. Yep. Yeah, I would say more or less that's the case. You know, yeah, if you run out, it's always going to provide that $15 minimum benefit no matter what. So even if you are already receiving in excess of your income replacement level, you're still going to get something out of the plan.
Okay. My second question, I know the standard is offering equivalent plans to quite a few school districts. How does the proposed short-term disability plans align with your equivalent plans? Is there any difference?
No, it's the same way. Yeah, it's
okay.
The equivalent plan mirrors the state plan.
Okay.
Yeah, so anything that you're doing with OEB's short-term disability plans is going to have the same impact whether the entity is going through the state plan or whether they're going with a private equivalent plan.
Okay, thanks. Tom.
Can we go back one slide? I just need some explanation.
Sure.
So what I'm looking at is premium on the current is premium about 2.2 and claims 1.7. So that's like about a 80% claims going to 80% of the premium going to claims. And what you have under expected is now 400,000 versus 100,000. So 25% of premium going to claims. And
yes,
what I don't understand that it just seems off, but I don't know anything. I don't know anything of what claims adjudication means.
Yeah. So essentially anything from general expenses, claim adjudication, and risk charges, those are all the expenses for standard just doing business. So outside of what we pay for claims, the other expenses don't change for us. So although we are going to pay out less in claims, the work is still going to be the same for us. The level of the level of claims we receive would still more or less be the same, because even though someone may not be eligible for much than a minimum, they're still eligible to file that claim and receive benefits.
So what happens is that you have to go on and do the same amount of work, even though you're going to give them, instead of $900 a week, you're going to give them $1,280.
Right. Yeah. Okay. So yeah, as the premium gets higher, the expense ratio is lower, but as the premiums get lower, the expense ratio is higher.
Okay. I understand now. It is kind of an odd situation.
I know it doesn't look good. I agree. Optics doesn't look great. But again, that's just the cost of us doing business. Yeah.
Got it. No, I'm not, no criticism.
JJ.
Yeah, I just have, I'm looking at the numbers of expected, and as I'm understanding it, you're saying premiums are going to go down by 80%, correct?
Correct.
Then in the current climate, that number is assuming you have the same enrollment. And I would be shocked if your enrollment didn't also go down by 90%. Because I know as a business person here at the county, if we have an employee who misses 12 weeks due to whatever, event X, and 3 months go by and they're going to miss another 12 weeks, I don't know that we're going to keep them. We're under no legal obligation to keep them. I don't know that we can hold their job for that much. So the likelihood that they even need your services is very low. I currently have one employee of our 480 that live out of state based on where we live. So it's quite unlikely that you'd have zero enrollees from my agency.
Yeah. Oh, I agree, JJ. I think you're going to see definitely a reduction in enrollment. Again, these are our actuarial projections. So whether they are spot on, I couldn't tell you.
Reduction in premium makes sense. Your reduction, those numbers are a farce. I'm just telling you, you're not going to get anywhere near that because hardly any agency is going to even use this, in my opinion, in Oregon, let alone even with a 80% reduction in premium. I think a lot of the places where you have employees who live in another state might. The challenge is Washington also has a paid leave program. So the Portland Metro folks, you have a lot of folks who live in Vancouver and live and work in Portland. They don't need your services either because they also have paid leave. So you're looking at people who live maybe in Ashland or maybe live on in the eastern.
I agree with you, JJ. I think that it's really going to come down to, do folks want to just have that extra level of protection? It's not going to cost them very much to have it. And so it's just a question of personal preference at that point.
Yeah. I'm cool with any agency that wants to have it. I just think that your numbers here are fantasy land.
Yeah. Okay.
So David, I have a follow-up on that. We have lots of collective bargaining agreements that have mandatory employee paid, mainly because of the tax implications, right?
Right.
Why should we continue the mandatory at all at this point? Because, and I'll say it bluntly, if we have contracts that have mandatory plans, then we're gonna have to go back and bargain all that out. But if you don't offer the mandatory plan, then that makes it easier.
I mean, that is absolutely an option if that's what you want to pursue. This is completely a board decision on what plans they want to continue to offer. So, but yes, I agree. I think that, with the mandatory plans, our school districts want to going to want to continue to pay for these, or are these, I think it was Ben Lapine, I know had a bargained unit where they had the mandatory employee paid. Are they going to want to continue to do that? I don't know. And that's, with the paid leave Oregon, we've talked with a lot of school districts just about what paid leave Oregon is. So I think that everybody has a pretty good handle from the district standpoint, from the entity standpoint of what paid leave Oregon is. And I think now they have to look at what their benefit package is going forward and what they want to offer.
Thanks. Appreciate it.
Yeah, absolutely. Any other questions before John talks about what Mercer proposes? Great.
Okay, just to round us out here, we've looked at this and the proposed reduction rates, seem generally reasonable. We did hit upon that same thing that Tom had highlighted, just trying to understand the dynamics there, and that does make sense. I think there are just a couple places where we might differ, but again, this is probably something that's going to be more productive if we engage with the standard directly over the next month. And this is really in terms of, is it, are we reducing it down to 8 plans or 5 plans and things like that. So I think that we just want to work that through with the standard, and then come back to the board with a concrete recommendation in the April meeting. So any questions?
I don't see any, John.
Okay.
Great. Thanks everybody for your time. I appreciate it.
Yep. Appreciate your time. Thank you.
Thank you both. All right, so we are going to move to, and we are like 2 minutes ahead. We're going to move to the communications plan update. Erin and Cindy.
Yes, thank you. And actually, Cindy's going to kick it off.
I am going to kick it off. Let me pull up what I was gonna. So we just wanted to spend a few minutes. I wanted to provide a little context and background for our plan for Erin. She's going to do all the heavy lifting. I'm just going to tell you why we're doing it. A few years ago, the PEB board, actually I believe he was the chair at the time, asked us to create a strategic plan for our communications for the PEB program. And about that same time, the Secretary of State did an audit of all of our operations and had some specific recommendations about communications. So between those two, Mercer put together a strategic plan for us. It's influenced a lot of the communications that we're doing now. And now that Mercer is our consultant also for OEB, we asked that maybe they do the same for OEB so we can more strategically look at how we're going to do our communications going forward. We are already trying to align the things that we do. We're looking at our website and newsletters and things like that. So I just wanted to kind of give you a little background on why we're doing this, and Erin's going to go through how we did it and what we're going to do going forward. So I'll let you do it.
Thanks, Cindy. Appreciate it. So on the next slide, we have just a summary of what we were trying to do with this strategy. So ultimately, we were trying to create or provide communication recommendations that help identify priorities so OEB can educate members about OEB in general and the board, promote member health and wellness, and also make benefit information more accessible. And the recommendations and ideas that I'm going to share with you are really intended to build on what OEB is already providing to members. And so, in partnership with staff, we would work through the new communications that would be implemented based on priorities, budget, resources, et cetera. So I'll give you, on the next slide, I'll give you a little background of what we looked at to create the strategy. So ultimately, we went through 3 different phases. So we did an exploration phase where we did interviews with various people around the state. We did an evaluation of the existing communication materials, looked at the current website, and then we also compared against survey results and benchmarks. And I wanted to draw your attention to the blue box there. We definitely are also intending to review the vendor partner materials to find out what they have available and what they can provide. So following the renewal process, we're going to be reaching out to each of the vendors to do a complete inventory, and then we will take what is provided by the vendor partners and weave that into the communication strategy where appropriate. We do want to make sure that OEB is fully leveraging what's available from the vendor partners. So then on the next page, thank you. So I mentioned that we wanted to build on the communication that OEB is already doing. So wanted to provide a summary to you here of what OEB is currently providing. I won't read each of the bullets in detail. I only have 15 minutes, but you can see that OEB is already providing a wide variety of communication, a lot of things around open enrollment. There's a virtual benefit fair that has a ton of education and wellness information available. There's the monthly education through the benefits and wellness newsletters and the vendor partner webinars. There's an interactive wellness guide. We're pursuing potential chat options for the website. We have a new hire video that's in process, and then some other things like the member services survey that happens each year with reminder emails, et cetera. So again, already a lot of communications that are happening. So on the next slide, wanted to share what we heard in terms of the key themes from the interviews. And we categorize them into 4 topics here. One is communication preferences. And we heard through the interview process that email communication is the preferred communication. And I will talk more about emails in a little bit. So while it's preferred, emails could be more concise. They could include some video clips and then maybe highlight key information. Also, open enrollment, wellness, and preventive care are helpful topics that members want to hear more about. The benefit website and the vendor partner communication. So the website it has all the information that members need, but it could be more user-friendly and modernized with more engaging tools and straightforward language. But then on the vendor partner side, maybe those communications are not being read, maybe too dense, and certainly something that we would be looking for when we do that inventory. Third thing was suggestions for improvement. So members want creative and engaging communication, such as social media and videos, more webinars, text messages, chat services, and that education about OEB, which is something we already knew about, and more specific content for new hires would be helpful. And then lastly, benefit questions. So people have questions about benefits, such as what are the costs? What is a copay? What's a deductible? What are the eligibility requirements? What do I do in a life event when I get married or have a baby? And so that there's specific topics that people need more education about. But then generally, members seem satisfied with OEB benefits. And I did just want to draw your attention to the note at the bottom there that, something that we need to keep in mind as we're thinking about all the different communications is that there are hurdles that OEB faces when connecting with members, just because there are differences in terms of the plans and the wellness programs that are offered, paycheck costs, retiree benefit offerings, et cetera. So we need to just keep that in mind as we're thinking about how to communicate broadly to OEB membership. So on the next page, thanks. So just a summary of the strategic goals. Again, I won't read this in general or in detail, but we were with the recommendations looking to make sure that we support and align with the board's objectives, that we are building awareness of OEB as an organization, that we're providing better education to members, that we're increasing engagement, and that we're communicating with members' preferences whenever possible. So those were the kind of 5 overarching goals there. And then on the next page, this is a summary of the different focus areas and where our recommendations are targeting. So what we're calling OEB 101, so educating members about OEB and how it supports members. Benefits 101, so helping members understand how their benefits work. There's emails and websites, so improving and enhancing these valued member resources. And I'm just kind of going around counterclockwise here. Mental health, so increasing awareness of and access to mental health resources that are available through OEB. Local support, so providing more support to local benefit administrators, HR, and unions to make sure that they can then support their members. New hires to create additional consistent resources. And then lastly, inclusive communications to make sure that we are, providing inclusive communications whenever possible. So now on the next slides, I have details about each one of these things. So we'll start with OEB 101, which is on the next slide. So on each of these, we have a number of recommendations and ideas that I'll run through quickly. I know we are short on time, but so in terms of educating members about OEB and how it supports members, thinking about things like fact sheets about the key components of OEB, maybe a series of videos that could be posted on OEB's website, and also an OEB playlist on a YouTube channel, on OHA's YouTube channel. Creating an infographic about how OEB benefits and costs compare to other organizations, potentially an organizational chart showing how OEB operates and kind of how that impacts you. potentially testimonials from members and or leaders such as like superintendents, somebody, people who could speak to the value of OEB and how that has been a positive change for members or how it's good for members. And then also using some stats to show members how OEB compares to other like organizations. So again, this is a bunch of ideas, but wanted to, see these are some of the things that we're thinking about. On the next slide, we have benefits 101. So you'll see things like, again, more videos since that has been a specific request, but videos that help explain the benefits, also making vendor partner videos more accessible. There are already some that exist, but if people aren't finding them, we need to make sure that they can find them. Potentially looking into digital tools, potentially an open enrollment learning module with gamification that's maybe tied to a reward or maybe a charitable donation, trying to make that more fun and engaging. Potentially a plan comparison tool or a premium estimator if that's possible. We want to collaborate potentially with vendor partners on data-driven communication. So thinking about things like how many people used a certain received a certain preventive care service last year. Trying to drive more usage of that benefit, if we can get that from the data. Looking at benefits at a glance with short, easy to read descriptions. Again, more infographics about how OEB plans compare to others. And an interactive life events guide. That was a specific request that came up and certainly, probably one of the questions that member services gets a lot. So, what do I do when I have a baby? What do I do in a divorce situation? So helping people work through that. And then also continuing to use Did You Know series. So, we have those monthly newsletters. Can we use part of that to highlight underutilized programs and services? So on the next slide is the website and email. So we definitely want to, we know this is a valued resource. We want to enhance it, expand it, review the organization and the content, make recommendations for better site usability with less clicks, add new sections to address some of those information gaps that people have asked for, like new hires or like the board. And some of these pages exist already, so it would really be building out content for, so it's easier to find for people, or easier for people to find. Adding a live chat option. Also aligning with PEB. We've started doing this work on the PEB site, so we want to take what we've learned from doing, from working on the PEB site and take those learnings and also apply that to the OEB site. And then potentially adding like a member testimonial section where people could add their own stories, maybe about self-care or wellness. And I think that's definitely something to explore, but to add that kind of social component to the website. We talked about doing some digital focus groups. So regarding communication preferences and tools, we did do digital focus groups on the PEB site around the website specifically, but this would be a broader ask about how they like to get communication, what they want to see from OEB beyond just the website. And then also providing concise and engaging open enrollment emails. So taking some of those tips that we got from the interviews and adding them here. Okay, next slide, sorry. And I see time's running out, so I'm gonna get going. Mental health. So we have adding a new section on the site, highlighting resources, adding a button for quick access, adding a section to the virtual benefits fair that doesn't exist right now, collate or, getting all the vendor PDFs around this topic together, and then potentially creating an interactive guide that is specifically around emotional well-being for people. And then on the next slide, local support. So we do want to make sure that local support has everything they need to support their members. So potentially a communication checklist with a summary of resources, a toolkit with member-ready items. So here's an enrollment checklist you could give them. Here's, enrollment instructions. Here's a magnet with the OEB member services information. Here's a print-ready poster that could be used at on-site locations. And also a member-ready email that potentially like superintendents or principals or whomever could distribute, but ultimately trying to put tools into people's hands that they don't really need to do anything about, they can just use with members directly. On the next slide. All right, new hires. So thinking about an interactive learning module, thinking about an enrollment checklist, more vendor partner videos, a digital plan comparison tool, which I mentioned previously, again, short how-to videos, and then also frequently asked questions, but really all these things that are targeted to new hires and trying to get them to enroll within that 31 day deadline. All right, I think there are, is it 2 more? Oh no, that's the last one. All right. So in terms of inclusive communications, want to make sure that we're providing at least Spanish translation for all materials, including all vendor partner materials. And we are going to be specifically reaching out to the vendors to let them know that that is going to be a requirement for them to be able to provide everything in English and in Spanish, but then also in providing instructions about how to request materials in other languages. And then doing other things like plain text versions, closed captions on videos, on-demand printing, ADA compliance, and certainly promoting diversity, inclusion, and equity throughout the communications. Okay, next slide. So that's a summary of all the different recommendations. Did want to make a note about emails. I know many of you think, people don't read their emails. Just want, we heard from the interviews that that email is the preference. From the latest member services survey that was done in November, you can also see that emails was the overwhelming choice in terms of how people want to prefer or receive communication. However, we do want to make sure that we note the suggestions from interviews about making them more concise and straightforward, trying to include engaging content like videos, and then highlighting new information. So we will be working to implement these recommendations to make videos better for people. All right. Last thing, I think. Super. Oh, sorry, 2 more things. All right, so implementation. Implementing new communication takes time, and we certainly looked at a lot of different recommendations and ideas. So we would be working with staff then to determine priorities, available budget, resources. Is it a Mercer thing? Is it an internal staff thing? Timing, but really working through how we can start implementing these things. We would build timelines for each. We'd refine that project plan. We'd actually create the communications. And then last but not least, we would certainly want to test and measure the effectiveness of the communication, and then report back to the board. And anything that is not working, we certainly want to reevaluate and adjust on our approach. All right, so then last slide. Oh, maybe I didn't include it. Never mind. That would be it. Ultimately, what just want to say in terms of measuring results, we do, we're going to look at like open rates on emails and website usage rates. But if there's any other feedback that y'all have about how to measure communication, we'd love to hear it. We certainly are thinking about also things about like less noise from your membership, positive feedback, positive comments, and what you think of as success in terms of communication. We'd love to hear that, so we can certainly incorporate that and respond to that.
Okay,
and that's
thank you,
officially
Erin
it. Yes,
and Cindy.
Speedy.
Any questions or comments? Okay, well, thank you. We are moving on to the legislative update. Glenn. How about we're going to use a little flexibility here, and we're going to move on to the CL report if Tom is ready to go.
I'm ready to go.
Let's go.
CL had a very interesting conversation this morning. We ended up first talking about benefit changes and medical dental initiatives, and then we talked about what we're recommending for clinical performance measures for the next plan year. So first, we looked at the medical plans and what they're recommending. Kaiser Permanente has a suite of program-wide initiatives that include sepsis treatment, additional support for maternity, particularly being able to do home visits, remote patient monitoring expansion, transitions of care with skilled nursing, which has been a huge problem area in the state, urgent care redesign, KP at home, which is basically hospital services at home, increasing e-visit chat and other digital solutions. These are a package and they are embedded in their system. Benefit changes that they're looking at is moving colorectal screening to new guidelines, which I believe start at age 45, a naturopathy benefit, and lowering insulin cost share caps from 75 to 35. We agreed with all of those. MODA medical initiatives, they had two which we thought were highly innovative, but we ran into problems with them. One was a flex fund and another was a meal program. These were focused on people with diabetes and able to address lifestyle issues and to support people in their homes. Problem was that, like, the flex funds was actually giving people money, the meal programs was delivering food to homes for 2 weeks after hospitalization. Problem with them is that they would be viewed as income and taxable, and we had no way of being able to connect with payroll and things like that to be able to do it. So we declined that as a recommendation. They have expanded language services, which they believe is at negligible cost, which we agreed with, and then VERTA, which is a program for people with type 2 diabetes with aggressive lifestyle management, focus on actual reversal. This one has, as you heard earlier in our budget conversation, has a cost of, I believe, about $100,000 for the first year, and yet in the year 2 we think that there's savings. So we recommend to the board to include that. The rest of the conversation around medical initiatives are ones that Mercer is talking to us about. And these are multi-year strategies that we think address the triple aim of increased clinical quality, better patient satisfaction and engagement, and decreasing costs. Under musculoskeletal, they're looking at, and you'll hear more about this, as centers of excellence for specific surgeries, second opinion. We spent time talking about regenerative medicine, which is this platelet-rich plasma extraction and then injection into various things. There's promising data around its use in several conditions, including knee arthritis. Problem is there's no clear long-term evidence yet, and we know that it's not ready for prime time yet, but is something that we will continue to follow. Doula coverage. Doulas are people who help pregnant women and during their deliveries in regards to supplementing the medical component of it. It's more person and patient focused, and there are certain populations where we feel that this is particularly helpful. Some interesting studies have shown decreases in cesarean section rate, pain medication use in labor and delivery. It's supported by the American College of OB/GYN. Our recommendation, this actually is now part of the Oregon Health Plan. So Kaiser Permanente and MODA are already participating in this, and what we're looking at seeing excuse me. We're looking at seeing what experience that MODA and Kaiser have, and then potentially having a October 2024 launch, and we'll look at cost implications and the like. The final conversation had to do with looking at a holistic coverage of metabolic disorders, and this is the overlap of type 2 diabetes and obesity. We know that this is one of the critical issues for our population. With so much of the long-term downstream costs around heart disease, kidney disease, osteoarthritis, cancer, all related to these issues. And the question is how far we can move move to the left in regards to coming up with new programs. So as an example, the VERTA program, which we think is ready to be brought on board, actually has the potential of preventing, or at least preventing diabetes. We have pre-diabetes programs, both with Kaiser Permanente and MODA. So all of those are ongoing and they will take time. There's a significant area of interest in some new diabetes medications that also have been shown. Significant number of people have weight loss associated with them. So it actually starts dovetailing treatment of diabetes and obesity. Coverage is different between KP and MODA. We need to look at that and come up with, see where alignment is reasonable. This is something that we are going to be addressing. It's possible that we're underutilizing things like bariatric surgery. So there's a long-term commitment to start, again, looking at this intersection of obesity and diabetes. We know that if you have significant weight loss, you are able to prevent diabetes in people who have pre-diabetes. There may be some diabetes remission. Hypertension can be controlled. Sleep apnea can be significantly controlled. Osteoarthritis, several other medical conditions. And so what I'm describing today is basically a long-term intervention program that we are going to be putting together. My hope is during the summer we'll be able to get Mercer with the clinical people from MODA and Kaiser Permanente, along with OEB and PEB staff and CL representation. The final issue has to do with clinical performance guarantees. This is for the 23-24 year. It will be a measurement year of 2024 because that's where HEDIS and the benchmarking come. And we eliminated a couple ones that were too generic and did not give us important information. It had to do with weight assessment and counseling for children. We're interested in continuing diabetes eye exams, looking at statin treatment for cardiovascular disease, and we're adding 3 that we're going to be watching: well child visits in the first 30 months, cervical cancer screening, and controlling hypertension. We are also looking at adding racial and ethnic disparities for controlling hypertension, breast cancer, colorectal cancer screening, and diabetes control, and well child visits in the first 30 months. We may need to also include some geographic subsets to be able to see if we're having problems because of geography. We're not going to change the methodology of scoring that where the administrative fees are at risk. And finally, for dental, we are looking at right now we have a couple report-only measures. The problem with dental is that there isn't national benchmarks that we can compare to. We are looking, though, at getting the dental plans together and come up with plans. One of them that's particularly interesting is doing a measure around oral evaluation for people with diabetes, where we would be pulling the medical and dental plans together in terms of figuring out how to look at a medical condition that crosses both the medical and the dental sphere. So that is it. Any comments or additions that CL members would like to add?
accurate.
Thank you.
Okay, so thank you, Tom. We're going to move on to Glenn, legislative update.
Sorry about that earlier. For some reason, my camera blanked out on us. So let me just very quickly pull up a update here. Yeah, the legislative session, we are, as you can know, we're about a month and a half into the session. We continue to work on a number of high priority bills, and I'll quickly go over those. And about 38 bills that really could have a financial impact on PEB and OEB, but we're following those. So I would say, just to give you a brief update on or the status of ones that we have been following that I reported on back in February, the global budget pilot, which is supported by Representative Dexter. It was referred to the House Healthcare Committee, but no hearings have been scheduled. The Senate Bill 403, which would allow OSP retirees, it's Oregon State Police officers, had been referred to Ways and Means, but has yet to get through a hearing. House Bill 3140, which would remove the 3-year consulting RFP requirement on us, does have a hearing scheduled on March 15th. And we did have a new one that just came up for us. It would make a slight modification to the board membership. It would add one member, and that one member would have to be employed as a classified staff at a public school or ESD. It would also reduce our health policy representatives from 2 to 1. It applies to vacancies that are in effect at the passage of the bill. This did have a public hearing, and but has not been scheduled for a work session yet. Those are the kind of high priority bills that we're following at this time. Before I move on, I just wanted to know, for those bills, did folks have any specific questions on them? Okay, I'll move on.
If they have hearings on the changing of the board membership, there will be opportunities to testify. I think that there's some value that some folks at OEB, either board leadership or Ollie or someone, on the value of having 2 health policy experts.
Well, they already had the public hearing. Problem is that we didn't really catch this bill until after the public hearing. They would move on to a work session now where they won't have any testimony.
All right, well, if there's opportunity for us to comment, I would like the opportunity to do so, or have someone do so, because that directly affects us, this board, and I see a ton of value in having 2 health policy experts, as someone who is not a health policy expert.
Well, we'll be doing the bill analysis, and certainly if folks have comments on that in regards to that change, then I would recommend you send them my way, and then we can include it into the bill analysis, which then goes on to the OHA leadership and also can be transmitted to the governor's office, who is the representative for the executive branch.
Yeah, like Glenn said, I mean, we have to remain neutral on bills, but if you work through, whatever constituencies or stakeholder groups, that's definitely something you can do for sure.
The other ones, of course, that we are following that are not a priority one in the sense they don't affect our programs really directly, but they do impact us, especially from a financial standpoint, is the infertility benefits. Just had a hearing. It has a price tag the same as it did last year because it's pretty much the same bill of 0.6 on the PEB side, premium increase, and 1.3% on the OEB side. This has been put into a bill analysis and sent to the leadership. It also will go into the fiscal impact statement because we will get a request for that, which goes directly to the legislators. There is a bill, Senate Bill actually 283, which actually dealt with a lot of different things in regards to education. But one of the big things it dealt with was how to kind of fill the gap for substitute teachers. And one part of it would allow substitute teachers to have health benefit coverage. We worked with Mercer and they estimated that that could increase our premium rates by 2% on that because there's roughly, we're looking at, there is no specific tally that's done every year, but what has been reported has been around 4,000 substitute teachers, and that even if you took just the 25%, which is 1,000, which Mercer did, you could see a, premium increase for both medical, dental, and vision by 2%. Prescription drugs, we've got a number of bills on PBM limitations. Not all of them have really moved, but there are a few, such as the drug copay calculators, which is coming up for a public hearing. The bill on modifying our current Senate Bill 551 program, that actually has a work session next week, and they just released an amendment which made some changes in regards to how the eligibility is done. It probably won't have a direct fiscal impact on us because we are not the ones, the agency that reimburses the colleges and universities for this program is actually over at the Department of Education. We again have a number of health equity bills, gender affirming care, health interpreters, some behavioral health bills. And then we have one regards as kind of an omnibus bill, and it has a whole section on reproductive health rights and providing people the ability to sue if they feel that their reproductive health rights have been interfered with, which could have some impact on PEB and OEB as well as OHP in regards to using, in regards to covering benefits, as well as in regards to using plan management, utilization management. The Universal Health Plan, this is actually creating an organization to implement a universal health plan by 2027, coming up with an implementation plan, and then bringing that back to the legislature in 2025. We have some other various ones that are coming up, such as hearing aid coverage, sickle cell, a number of benefit mandates that are coming really, kind of across the legislature's desk. Basically, what you're looking at right now in regards to timing is that the legislature has until March 17th to schedule work sessions and their policy committees. If a bill does not have a scheduled work session and does not pass out of a work session in the first week of April, then it really is pretty much dead unless it's been sent to Ways and Means, Rules, or Finance and Revenue. But there's been, a lot of pieces of legislation out there, more than actually 2017, which was kind of over 2,000, they said so far. Are there any questions that folks have, and you know, any other pieces of legislation that you wanted to hear about, or?
And I just wanted to add, this is Ollie. Robert and I and the PEB board chair are presenting to the Ways and Means Committee on Tuesday, March 21st, and we will send out a link if anyone wants to watch that meeting. But we'll be up with the as part of the health authority, and they actually kind of treat us special and give us our own presentation. Even though we're not technically a separate division of OHA. Just want to give you a quick heads up there.
Tom,
Sorry,
you had a question?
Yeah, just in regards to what Ali just said, I would hope that they understand the struggles that we have, and that any type of addition, benefit addition that costs OEB and PEB would include in it an exemption for from the 3.4.
Yeah, I haven't seen that yet.
Well,
yeah, we put a disclaimer. Yeah, we put a disclaimer on our physical analysis, Tom, and bill analysis for sure. I mean, because it has a budgetary impact on us, any bill that would impact our rates. So that's,
well, I mean, but as again, it sounds like this is Ways and Means gets a lot of these bills, or I would assume, and having them hear that as compared to a disclaimer, you know, I'd be wearing a coat with it, you know, kind of written, spray painted on it.
Yeah, we definitely talk about that as part of our presentation.
Okay, perfect.
Yeah.
Perfect.
Yeah.
Thank you.
Yeah, you bet.
All right, well, I'll come back in April and kind of give you a, you know, a further update. I'll have also more kind of on status of what's moving and what's not moving by that time, because they'll have a lot of the bills weeded out by then.
All right, thank you, Glenn.
Thank you.
We are moving on to the innovation work group. Go.
Okay, slides coming up. Next slide, please. So updates from the innovation work group have been pretty short for the last few months. So I thought it would be good to share with you some of the learnings that we've had and where we're going for the balance of the year. As I've said before, it's been a learning journey as we've waded into this. And one of the things that we had to overcome was a perceived difference in the data sources and pursue a particular area. The other thing that we did is, with the data that we've got so far, we did develop a straw plan to just kind of lend some perspective of how this might play out. So we're about to receive some more data, which should give us a longer look at things and give us a more credible data set to work from. So what we're looking at coming forward in the spring, which is to develop facility contracting requirements. So we can get that settled. That'll enable carriers to negotiate that. We've looked at a couple ways of scoring, and we'll finalize that metric and framework. We'll finalize plan design options based on data, and we'll look at stakeholder engagement, of course. We should be reporting a more comprehensive progress update after we've done the renewal, so figure May or June. And during the summer, we'll get more quality data to update things as we prepare to make a recommendation in the October-November framework. Next slide, please. But I thought it'd be good to share with you a couple of observations that we have seen. This slide, based on the shorter data set, shows what percentage of people are actually being treated in the area that they live in. And there's three of note here that the coast and the Northeast and even the Southeast, that less than 50% of these surgeries are performed in their backyard. So there certainly is a willingness to travel when there's a perceived value outside of their home area. You'll also notice that there's an other category. And since we're using APAC data, other basically means out of state. And this will probably challenge us to review along the borders of Southeast Washington and Idaho for those living in the Northeast area, because you'll see that 23 out of 28 or 23, nearly half go outside of the state area for that. So I think we'll have to look at, once we've got all of the criteria defined, to see whether there's a couple of extra facilities that will give greater access to people in that area. Next slide, please. So as we've done the preliminary ranking, it's pretty interesting to see the slope. You can see that on the left side, which we've labeled tier 1, these are the best, these are the facilities showing the best results. There's 14 of them. They're not all in Portland. And then as we go down into tier 2, you can see it levels out quite a bit. And so one of our challenges is going to be to decide whether tier 3 is limited to the 6 in the box to the right, or whether that moves another 9 to the left where there's a little bit of a blip that comes down. So we'll determine that after we have more data, and we'll see whether a greater difference emerges at that. But just wanted to let you know what we're up to. The fact that the information that we're gathering is interesting. And while you may say, well, how many numbers are there? How many surgeries? Is this really, what's the impact going to be? But one of the rich things that should come out of this project is that we will have established a model, not only for looking at centers of excellence for knee and hip replacement, but then in years to come, we will add to that spine and neck, shoulders and elbows. So it's really important that we get this first edition really set on solid ground. And hence, that's part of the reason why it's taken as much time as it has. JJ, do you want to add anything to that?
No, I think you covered it pretty well. I mean, the big thing, especially on this slide here, is this is where we are today. We're looking to make some changes. The objective is to create a system that's going to give the best care and save the system money. So hopefully that'll happen in the months to come.
Yep. Any questions? If Margaret's on the line, did you have anything to add, Margaret?
I didn't have anything. I think that was a great overall review, Jeff. And just to note, I think 2023, these next 6 to 9 months are going to be a pretty busy time. There's going to be a lot of work going on. So we will certainly be coming back to the board with more comprehensive updates and additional information. Also, as part of those comprehensive updates, wanting to understand from board members where their questions are, where are there places where they're needing more information or more analysis from us, so that we can pull together as robust as possible of an option.
Good. Okay, thank you.
Well, thank you, group. And we're moving on to the director's report. Ali.
Yeah, thanks, Robert. Just quickly, sent an email out last week